Assalamualaikum warahmatullahi wabarakatuh. Good afternoon, ladies and gentlemen. Welcome back to Top Scientist Webinar World Class University with the topic Update Technology in Dentistry. Now, we will continue the second session, a presentation from Dr. Dan Johan Apps, DDS, PhD, Paid Dent and Special Needs, MSc, DMFR from Artevelde University of Applied Science, Ghent, Belgium, and will be moderated by Dr. Gigi Cekdaramanja, SPRKG Consultant. Dr. Gigi Cekdaramanja is a lecturer from Dental Radiology, Department Faculty of Dentistry, University of Sumatera Utara. We will welcome to Dr. Gigi Cekdaramanja to introduce to our second speakers.
Thank you for MC, Dr. Intan, for the opportunity given. First, I want to say hello to my beloved lecturers and participants, whom we respect, Dean of the Faculty of Dentistry, Universitas Sumatera Utara, the Vice Deans of the Faculty of Dentistry, Universitas Sumatera Utara, today's speaker, Dr. Dan Johan Apps, DDS, PhD, MSc Paid Dent and Special Needs, MSc, DMFR, the lecturers who have been present, and the participants of the Top Scientist webinar. Assalamualaikum warahmatullahi wabarakatuh. Good afternoon. Greetings to all of us. Distinguished guests, as has been announced, today's webinar has the theme Update Technology in Dentistry regarding dental radiography in general dental practice. For that, we all really need information as well as an effort to equalize perceptions, as we hope together in this webinar. Before presenting the material, let me give a little introduction related to the material that will be delivered by the presenter. Basically, scientific forum like this are very important and interesting for us to follow, because we will get a lot of information. Therefore, it is hoped that all attendees will be able to pay attention and follow the webinar as well as possible. All right, next I will read the speaker's CV. Johan Apps graduated in 1993 as DDS from Ghent University, Belgium, and obtained subsequently an MSc in Pediatric Dentistry and Special Needs 1997 and a PhD 2002 at the same university. In 2008, he obtained an MSc in Dental and Maxillofacial Radiology at the University of London. From 1993 till 2004, he was employed part-time as private practitioner and faculty at the Ghent University and Ghent University Hospital. From 2004 till mid-2012, he became full-time faculty at the same institution. In July 2012, he moved to Seattle, USA to become full-time faculty at the University of Washington, where he was head of dental and maxillofacial radiology. From February 2018 till December 2020, he worked as head of dental and maxillofacial radiology at the University of Western Australia in Perth. Since January 2021, he is employed at the Artevelde University of Applied Sciences, Ghent, Belgium, and works part-time in dental practice and collaborates scientifically with the University of Groningen, the Netherlands, and University of Brussels, Belgium. He has authored several peer-reviewed papers, textbooks, textbook chapter, conference abstracts, and is a frequently invited speaker at scientific meetings. His main topic of expertise are dental and maxillofacial radiology, local anesthesia, diagnostic, and anatomy. Furthermore, we welcome the Honorable Dr. Dan Johan Apps, DDS, PhD, MSc Paid Dent and Special Needs, MSc DMFR to deliver his material. Dr. Johan, The time is yours.
Thank you so much for the very kind introduction. I will try to share my screen now, and I hope you'll be able to see the screen. I think, let me see, this is working. All right, I think you should be able to see the screen now. And first of all, I'd like to thank the organizing committee for inviting me in this very interesting meeting you guys are having. This talk will be about dental radiography in general dental practice. And at the bottom, you can see my affiliations, as have been already mentioned by my honorable colleague. First of all, we have to say something about radiation protection. I think radiation protection is important in order to understand what we do with our patients and how we can protect ourselves as well. Taking radiographs is one thing, but taking into consideration the radiation protection is another thing. It's actually very simple. There's 3 basic radiation protection rules, or 3 basic principles in radiation. And the first one is called justification. Justification says that you can only take X-rays if there's no other way to obtain the information that you really need. Justification also holds that patients who cannot understand the instructions to take the X-rays, for instance, a small child who will not be able to understand your instructions when you're trying to take a panoramic radiograph, for instance, you cannot justify the exposure. The next principle is called limitation, or it used to be ALARA, as low as reasonably achievable. In the meantime, it's been changed to ALADIPE, which stands for as low as reasonably diagnostic and individualized to each patient. It means that there's no such thing as a routine X-ray on patients. It means that you have to individualize each exposure to each individual patient. The next principle is the optimization principle, and the optimization principle should take both the previous ones into consideration, and at the same time, you should always try to take the best images possible. So justification, limitation, and optimization are the 3 basic principles, which means there is no such thing as a routine X-ray. So what about radiation doses and units? I'm not sure if everybody knows the differences between the 3 different radiation doses. So let's have a look at the doses. We've got radiation absorbed dose, or the amount of energy per unit mass of tissue, which means it doesn't take into consideration what type of radiation you're using. It doesn't take into consideration the type of tissue that's being irradiated either. The unit of radiation absorbed dose is the gray. There's only one country in the world that still uses rads, and that's the United States of America. 100 rads equals 1 gray. Then the scientists decided to have another unit and another dose, being the equivalent dose. And the equivalent dose takes into consideration the type of radiation. And that's where things can become a little bit confusing, because for X-rays, the weighing factor was determined to be 1. So when you look at X-rays, the weighing factor is 1, which means 1 gray of X-ray radiation equals 1 sievert of X-ray radiation. If we would be working with alpha rays, it would be a different story, because 1 gray would equal 20 sieverts. But as I said before, the weighting factor for X-rays is only 1, which in some literature, it might be sounding a little bit confusing, where some of the scientists made a little error and they switched the grays with the sieverts. But now you know the difference between radiation absorbed dose, equivalent dose. Now let's move on to the next one, being effective dose. Effective dose takes into consideration, or takes into account, the type of tissue that we are irradiating. And that is interesting, because it converts all doses to whole body dose, or equivalent whole body dose. the unit is the sievert again. What are those weighting factors for those different tissues? Well, if you look at the different tissues on this table, you can see like bone marrow is 0.12, but look at the thyroid gland, you see 0.05, the brain 0.01, etc. If we add up all these, it equals 1, which is a whole body dose. It allows us to compare radiation exposures between different disciplines. For instance, we can compare a periapical radiograph with a thorax X-ray, for instance. So what are the typical effective doses for dental and medical diagnostic exposures? Well, I've circled in red the most frequent radiation doses that we encounter in dentistry. So bite wing or a periapical radiograph, we've got a panoramic radiograph, and you see there's quite a big range for the periapical radiographs or bite wings. It depends on which image detector that was used, the milliamperage setting of your X-ray machine, the exposure time, etc. So there's quite a wide range, but if you're using rectangular collimation and you're using a digital image detector, we can assume that a bite wing or a periapical radiograph is about 2 to maybe 3 microsieverts of dose, effective dose. For a panoramic, most of the machines produce about 24 microsieverts. Why is there such a big range? Well, some of the machines, panoramic machines, can take a panoramic X-ray in 5.4 seconds. Others take about 10 or 15 seconds, and that explains the wide range of effective dose. Lateral ceph, same thing. You've got one-shot machines and you've got scanner machines that take a cephalometric image. That's why there's such a big range. But let's assume it's about 4, maybe, yeah, about 4 microsieverts for a cephalometric image. Now look at these numbers, compare them with these two. 1400, 6600, that's a big difference. And that's exactly what I'm trying to explain to you, is that there's a big difference in what we're trying to do in dentistry and how we are exposing our patients. Our doses in dental diagnostic radiography are much, much lower than the ones used in medical. However, when we are using cone beam CT, you can see that it varies between 10 and 1100. And the 1100 comes pretty close to medical radiation machines, like the CT skull. Why is there such a big difference? And why is there such a big range in CBCT? Well, you've got small fields of view, you've got large fields of view, and anything in between. And there's a multitude of machines on the market. They are using different milliamperage, different kilovoltages, and different exposure parameters, and different exposure times. So there's a huge range of radiation doses and effective doses in dentistry as well, especially when we look at cone beam CT. Try to keep these numbers in mind, because sometimes patients will ask you, is that a high dose? Is this radiation examination a high dose? Well, in order to do that, you have to be able to compare the radiation doses. And this is a table that explains it very well. On the right-hand side, I've taken the average for Belgium or Europe, for instance. You can see it's 2,500 microsieverts per year. Keeping in mind the figures I just showed you, there's about 2 microsieverts for a periapical, 24 microsieverts for a panoramic, and there's about 10 to 1100 for a cone beam CT. So that puts radiation doses in perspective if you have any questions from patients. So for Europe, and I'm not sure about Indonesia, but for Europe, it's about 7 microsieverts a day. I know in Australia, it was about the same thing, about 6 or 7 microsieverts each day of natural background radiation. In the United States, however, it's about 10 microsieverts a day. And that is because there's a difference in the composition of the soil. So the rocks and the soil itself is quite different, and there's more radiation from, for instance, radon. On the left-hand side, you can see where the radiation, the natural background radiation, comes from. And there's a whole bunch of resources or sources where that radiation came from. So what about the effect of these doses? Well, on the left-hand side of this table, you can see the doses in microsieverts. And as I said before, dentistry is using very low radiation doses. And we are definitely in this area, which means nothing is going to happen to our patients when we are taking x-rays. The only thing we need to take into account are the so-called stochastic effects. We do not cause any deterministic effects in dentistry. If you look down this table, you'll see that the dose is increasing rapidly from 2,500 to more than 100,000 microsieverts. This is never going to happen in dentistry at all. In medical exposures, you might get into this region where there's 2,500 to 10,000 microsieverts as acute dose. That might cause some hematological changes. We in dentistry, we can never ever cause any of these acute effects following whole body radiation doses. So what is the risk we are taking with our patients? Well, this is a table I found in a textbook from the UK, and this is a table that assumes or estimates the risk of a standard 30-year-old male patient developing a fatal radiation-induced malignancy from a variety of dental and medical X-ray examinations. And I've encircled in purple what we are doing in dentistry. And when we're looking down the list, you'll see some of the numbers are encircled in red. And I just wanted to point out that we are taking a quite relatively high risk on some of our exposures. However, if you can justify, when we go back to the first three basic rules, if you can justify the exposure, it's worth taking the risk because it will benefit the patient. If you cannot justify, then you should not be taking the X-ray. So on this table, you can see if we take a periapical or a bite wing, we're taking about 1 in 10 million risk to cause a fatal cancer in that patient. However, you have to keep in mind it's a healthy 30-year-old male. And there's a difference with females, and there's also a difference when you look at younger people or older people. So going down the list very quickly, you'll see lateral ceph is taking 1 in 2.5 million. A CT of the skull is taking a risk of 1 in 14,300. But when you look at cone beam CT, large craniofacial exposures, we are getting in the same range again as the medical colleagues. Now let's have a look at the multiplication factors that you have to take into account when we are exposing patients to ionizing radiation. And this table shows you very clearly that when you are dealing with small children, the risk has to be multiplied by 3. So if you're taking a bite wing on a child that's only 3 years, that's maybe 4 or 5 years old, you're taking a risk which is 3 times higher than the 1 in 10 million, which means you're taking 1 in 3 million risk to cause a fatal cancer. And you can see the multiplication factor goes down or decreases when patients get older. And it all has to do with the radiosensitivity of the body and the different tissues in the body, but also with the mitotic activity of certain tissues in our body. And it is very logical to understand that somebody who's like 60 years old, for instance, who will be irradiated, runs a lower risk to develop a fatal cancer because his or her life expectancy is much lower compared to let's say, a 10-year-old. So what are the biological effects of ionizing radiation? I've already mentioned stochastic effects, but let's go back to stochastic and deterministic effects and quickly explain the difference. So in the first place, what can happen is when radiation, ionizing radiation, hits the body, you can have an indirect action where the radiation interacts with water molecules and then causes ionization and excitation, which will create, for instance, H2O2, and that can cause molecular damage to our DNA. In many cases, we will get repair, which is good. Or, if we're unlucky, we can create a mutation. The X-rays, the ionizing radiation, can also interact directly with the DNA. And that as well will either go into repair or it will go into mutation. At the bottom of this slide, you can see this section here. And this section indicates that these actions, the indirect and the direct action of the ionizing radiation, takes place within picoseconds, like small fragments of a second, whereas the mutation and the replication of the mutation will take minutes to decades to develop. And that again explains why when somebody's irradiated at the age of 60 runs a much lower risk than somebody who's 10 or 15 years old, because just at the age difference, the life expectancy of the 10-year-old is much longer and larger compared to a 60-year-old. So as I said before, there's deterministic effects or tissue reactions, and there's stochastic effects. The deterministic effects are only happening when we are dealing with radiation doses over 100 milligray. 100 milligray, remember, radiation absorbed dose unit was gray. Sieverts are for effective dose and equivalent dose. Now we're talking purely about radiation absorbed dose, and we're going to have to deal with radiation that is higher than 100 milligray. So as I said before, this will never, ever occur in diagnostic imaging in dentistry because we never reach that high radiation dose. So in dentistry, we will not have to take into account the deterministic effects. When can it happen? Well, it can still happen in therapeutic radiation circumstances where patients are being treated with ionizing radiation for a tumor, for instance, or in interventional cardiology where the cardiologist surgeon is performing certain actions under ionizing radiation. So some of the examples of early tissue reactions might be erythema or mucositis, and we also have to deal with hyposalivation, which is a thing that we encounter in dentistry when we are seeing patients who have been radiated for head and neck cancer, for instance. Cataract is another example of delayed tissue reactions, fibrosis, hematopoietic reactions, so changes in the blood, and then there's radionecrosis, which is another thing that sometimes we are confronted with in dentistry. But again, it's not because of the dental radiation, the dental diagnostic radiation, it's because of some therapeutic radiation that has been administered to our patient. Stochastic effects are the ones that we have to take into account because the deterministic effects have only take place above 100 milligrays. We are dealing with a probability of an effect, whereas there's no such thing as a threshold dose. So the probability of the effect, but not the severity, is taken into account. And then there's no threshold that determines which effect will occur. So that is why the scientists like the idea of the linear no threshold model, because what they have done is they have plotted the effect in the dose. and they've said, okay, if we have 100, then this is what's happening. And if we have 200, this is what's happening. That's going to be the effect. So this here is 100 milligray. What the scientists have done, they have extrapolated that curve to, they've said if there's no radiation, then there's no effect. If there's a little bit of radiation, we cannot predict what might happen to our patient. And this is a model that is used all over the world. And so in dentistry, because we're using low X-ray radiation, low energy radiation, we have to take into account the stochastical probabilistic effects. So that being said, I think it's time to have a look at some of our X-rays. And I've collected a couple of examples, which I hope you will enjoy during this lecture. So this is a patient, 8-year-old girl, Can I Wait is her name, and Dr. Goodlooking is just took this panoramic radiograph because intraorally he noticed there's an absence of tooth 2-6. So tooth 6 has not erupted, and so that's the reason why they took the panoramic radiograph. So let's have a good look at what we are actually seeing. We are seeing a uniform radiolucent lesion which has some very small radiopacities near its border, and the radiolucent lesion seems to be enveloping the crown of the unerupted tooth. What else can we see? Well, the patient has tooth number 3-7, 4-7, 1-7, but where is tooth number 2-7? So 2-6 has not erupted. We have a radiolucent mixed radiopaque lesion surrounding the crown of the 2-6, and the 2-7 is missing. So what lesion are we looking at? Well, we're actually looking at an ameloblastic fibrodontoma, and what we have, what is actually distinguishing this from, let's say, a dentigerous cyst, for instance, is purely the fact that we are dealing with some ossified or calcified material within the cystic lesion. Another interesting thing is that the tooth number 2-6 was displaced superiorly. In this case, the surgeon decided to remove tooth 2-6 and to enucleate the entire cyst. This was the detail from that panoramic radiograph. Next case. This is a CBCT of a patient. He's a 25-year-old male who's in good health, but who uses recreational drugs on a weekly basis. And intraorally, we can see tooth number 2-7 is missing. This tooth number 2-7 is missing, and it's being displaced superiorly into the maxillary sinus. We can also appreciate some very small radiopacities within the lesion, which might be secondary infection, or you might be looking at calcified material within this radiolucent lesion. I want to point out to you that cone beam CT cannot distinguish between soft tissues. For instance, you can see this is the content of the lesion, but it has the same radiopacity as the mucosa that's covering the hard palate, the tongue, the cheek on the lateral side. So we cannot distinguish muscular tissue. We have the orbit here, and I just want to point out to you that it's very difficult to use cone beam CT to distinguish pathology on soft tissues. Cone beam CT is especially very good to look at teeth and bone. So what are we looking at? You can appreciate a well-defined but not entirely corticated mixed radiopaque radiolucent lesion that appears to envelope the crown of a superiorly displaced tooth number 2-7. The apex is encroaching on the superior border of the maxillary sinus, which is also the floor of the orbit. You can see here, floor of the orbit, and there's the root encroaching onto to the floor of the orbit. And here you can see the infraorbital canal. There are small calcifications inside the lesion, which have the radiopacity of dentin and enamel. So we are comparing this with dentin. It comes close to enamel, but it's less radiopaque than enamel. So that gives you a little bit of an idea what it might be. So your radiographic differential diagnosis should be the following. You can be looking at a calcifying odontogenic cyst. We might be looking at an adenomatoid odontogenic tumor. We might be looking at an ameloblastic fibroodontoma, or we are looking at a dentigerous cyst with secondary infiltrations. The answer to our question can only be answered by histology. But the radiographic image or appearance can help you distinguish between different possible diagnoses. This is another patient. This patient is 35-year-old male, and this is a panoramic radiograph. It's the first panoramic radiograph that's been taken on this patient, and the dentist is looking at it. And I'll have you have a look at this radiograph as well for a few seconds. But there should be something that's very striking. And if you look very carefully, and I'm pretty sure that many of you are looking at the teeth now, keep looking at the teeth and try to discover what's weird. All right. So one of the things that I noticed immediately was that there's a lack of pulp chambers in these teeth. This patient seems to be having, and he's only 35 years old, he seems to be having pulp obliterations. So are we just looking at just normal age-related pulp obliteration, or are we looking at somebody who's grinding his teeth very much and very often, and which is causing these obliterations in the pulp? Well, we are looking at dentinal dysplasia. It's not the same as dentinogenesis imperfecta, but this is a nice example of dentinal dysplasia. Usually, these patients do not need special attention, but it's a very interesting finding because sensitivity in teeth will almost be very minimal in this case. Now let's have a look at another case. We've got Emma. Emma is 10 years old and she's not taking any medication. She has 3 meals a day. She's got 2 snacks. She drinks orange juice or apple juice with the snacks. She brushes her teeth twice a day with fluoride toothpaste, but mum is not really happy with the way the teeth look. So I'll have you look at this radiograph for a couple more seconds, and if you look very carefully and compare it to the previous one, the previous X-ray, I told you that one of the first things that I saw was that there were no pulp chambers. Well, in this case, there's definitely pulp chambers. Another thing that is interesting is that the roots are normal, the dentin is normal, but what's happened to the enamel? And then when you look at the enamel, in the first place, you could say, well, there's caries, interproximal caries on some of those teeth. But when you look very carefully, even the non-erupted second molars, there is no enamel on those teeth. And there's no enamel on any of those teeth. So we're looking at a case of amelogenesis imperfecta. So when you're looking at X-rays, don't look at teeth only, of course, but in these few examples that I've given you, you should be able to identify very quickly what is going on. The next thing that I usually do is, once I've looked at teeth, I start looking at anatomical boundaries. For instance, you can definitely see a triangle here and a little triangular space there. That's the pterygomaxillary fissure, which is bordered by the posterior wall of the maxilla and the lateral plate of the pterygoid of the sphenoid bone. Then we can see the hard palate, and then we can easily identify within the maxillary sinus, we can see something that looks like a C and a J. And these are the zygomatic buttresses of the maxilla, and they will form the zygomatic arch. Then the next thing you should try to identify is the circumference of the mandible. And you can identify the condyle, you can identify the semilunar crest here, or mandibular notch. We have the coronoid process, the external oblique ridge, then we have the angle of the mandible, the antigonial notch, then we have the integrity of the body of the mandible and the symphysis. We can identify the mandibular canal in many cases, and then we have to try to find the mental foramina, and if you found them, you've got most of the landmarks. The next thing I do is I start looking at the spine. If the spine is visible, we can see the anterior arch of C1, we have C2, C3, and then around C3, C4, you should be able to see the hyoid bone, which you can see here. But it all depends on how the panoramic X-ray was made and how the patient was positioned. In some cases, you'll be able to identify the inferior border of the orbit much better, but I think in this case, it's not that well visible. Why do we have to look at these boundaries? Well, if there's any missing boundaries, there might be pathology spreading into the skull, or from the skull into the surrounding areas. Now let's look at an older patient. This is Germaine. She's 88 years old. She's got a pacemaker since 15 years. She's taking blood thinning medication, and she's about to receive a new hip in 3 weeks. The orthopedic surgeon is well aware of the relationship between oral health, implants, and the risk of endocarditis. She insisted that Germaine sees a dentist before the surgery. This is the panoramic radiograph who the doctor just took, and what would be her advice to lovely Germaine? Well, looking at this radiograph, we can easily see there's not a lot of teeth left, but now let's have a look at our anatomical boundaries. What we've got here is a pterygomaxillary fissure. We can identify the zygomatic arch. There's the zygomatic buttress on the patient's right-hand side. There's the zygomatic buttress of the maxilla on the patient's left-hand side. We have the articular eminence, the glenoid fossa there as well. What else can we identify? We've got the real image of the hard palate. We've got the ghost image of the hard palate. We can identify the soft palate hanging down. We can identify the soft palate there as well. And then we can see this area, that's the tongue. And in this case, the tongue was not perfectly against the roof of the mouth. Then looking at the continuity of the mandible, we've got the angle of the mandible where we have some irregularities for the masseteric muscle that attaches to the angle. So those are the masseteric tuberosities. And then we identify these small radiopacities. These are tonsilloliths. These are small calcifications in the tonsils. They're very benign. Okay, good. We identified the condyle, the mandibular notch. We've got the coronoid process. And then we see the external oblique ridge. We can identify the canal. And we do the same thing on the opposite side, on the patient's right-hand side. Again, I see something interesting. There is this thing and that thing sticking out. That's the styloid process. There is the anterior process of the atlas. And then we can also see this area here, which is the earlobe. And that looks all very normal. And then I look down the spine, and I see there's barely any space between C1 and C2. And then you see this here, this big radiopaque entity that's sticking out of the spine. That's an osteophyte. probably C3 because I see the hyoid bone here. So this must be C4, C3, C2, C1. And then we see this area here, and we can see the same thing on that side, and it's probably atherosclerotic plaque. So I'm just trying to show you how I analyze the image and how I come down to the tonsillolytids and the atherosclerotic plaque. And so I think it should be wise for Germaine to be sent to the medical physician to have her examined to see if there's more atherosclerosis going on. So on a panoramic X-ray, you can see much, much more than just teeth and jaws. There's much more information that you can actually identify on a panoramic radiograph. And I think I've just explained to you what I try to look at and where things should be or can be identified. So if you change the contrast and the brightness a little bit in the panoramic radiograph and you magnify the image, you can see the atherosclerosis pretty much in the carotid artery. The carotid artery splits into the internal carotid and the external carotid at the level of C3, C4, which is right at the level of the hyoid bone. And so if you see any calcifications in these areas, right in front of the cervical spine, you know there might be a high probability of you looking at a atherosclerotic plaque. In some cases, you can see parts of the thyroid cartilage, but the thyroid cartilage has a rectangular shape to it, and it's pointing towards the spine, and that can help you distinguish between atherosclerotic plaque and the greater horn of the thyroid cartilage. So are we ready for a few more cases? I think we are. I think we are. So this is another patient. He's 18 years old. He's got an intellectual disability. So it's very difficult for the patient to explain what he feels. But the story goes, he's not eating very well. He's been seeing this medical doctor, and the medical doctor has tried several things, and he's trying to get a good diagnosis, but he says, I don't know. And the patient's not eating as well as he used to before. So the doctor says, maybe we should try to take a panoramic, maybe we should try to send the patient to a dentist first, and the dentist can have a look. So the dentist has a look at this patient, listens very carefully to the complaint. Patient's not eating very well. He's acting a little bit weird. And so the clinical examination shows that there might be an issue with the wisdom teeth. And that's the reason why the dentist took the panoramic X-ray. And so he's looking at these wisdom teeth, and he says, well, they're quite okay. I don't think the wisdom teeth are the cause for the patient being a little bit different or behaving a little bit different than he did before. So let's have a look at our anatomical barriers, our anatomical boundaries. And one of the first things that I noticed on this patient is that this is the back of the maxillary sinus. And this is the back of the maxillary sinus. And I can easily trace it down there. And I can probably trace it somewhere here, but it's not clear anymore. And when you look very carefully, there's something going on from here all the way up to there. So this patient may have a cyst of the nasopalatine duct. The anatomical boundaries are not there anymore. I can't see the boundary on the right-hand side maxillary sinus that well anymore. And that's the reason why I tried to stress in the beginning that you have to try to find those boundaries in the first place. So if you look at these anatomical landmarks, you'll see there's that lesion. The teeth are slightly displaced. If you look at the angulation of the canine, the angulation of the lateral incisor canine, But on the patient's right-hand side, there is some more displacement. And I'm pretty sure if you look very carefully in the patient's mouth, there must be some swelling intraorally as well. So we have to include a nasopalatine duct cyst. We have to take into consideration a solitary bone cyst. We cannot exclude an ameloblastoma. Keratocyst is another possibility, and a central giant cell granuloma would be in my list as well. But in this case, it was confirmed as a nasopalatine duct cyst. We've got another patient here in our chair. He's got these small little conical teeth, and when you look at him, he's got blonde, sparse hair. He's very skinny, waits to speak until his mother says that he can speak. And so his mum is now interested to know why he has these particular teeth. Well, this is a very typical example of ectodermal dysplasia. You can see the number of teeth is limited. The shape of the teeth are very conical. And I gave you a little hint with the blonde, sparse hair. This patient has ectodermal dysplasia. The sparse hair indicates there's something wrong with the ectodermal tissues like nails, sweat glands. He's got blue scleria of his eyes, and very typically he's got hypodontia. We talk about hypodontia or oligodontia. Oligodontia is when more than 6 teeth are missing. We've got another patient in our chair. We've got a 46-year-old healthy patient who's got no complaints whatsoever. This is an incidental find, and this looks like kind of weird near the apices of the lower anteriors. And so it was spotted on a panoramic. The dentist decided to take a periapical X-ray and is now looking at this. And the dentist is considering going for endodontic treatment. However, when you look at these teeth, they look sound. There's no caries. There's no pieces missing from the teeth. So there's probably no trauma. So how would you carry on with this one? Well, in the first place, you have to try to do vitality testing. And it turns out all 4 teeth are vital. They're completely normal. So what are we looking at? Well, we're actually looking at periapical cemento-osseous dysplasia. Periapical cemento-osseous dysplasia is a very benign thing. It requires no treatment. It starts as a radiolucent lesion, and over time it becomes radiopaque, or mixed radiopaque, radiolucent, I should say. And in the final stage, it becomes radiopaque. And this is the final stage of periapical cemento-osseous dysplasia. And if you look very carefully, you'll see there's a rim of radiolucent material surrounding a radiopaque entity. And it's the same thing here. There's a radiolucent rim surrounding a radiopaque entity. And this is very typical, vital teeth, and this is just an incidental radiographic finding. A lot of patients are misdiagnosed and receive endodontic treatment, whereas it was never really necessary. Couple more. Looking at these 3 patients, they're 3 different patients, but they have something in common. What do they have in common? Well, we're looking at the mandible, and we are actually looking at the area of the molars. So we are expecting to see some anatomical landmarks. For instance, we can see the external oblique ridge. We are able to see the mandibular canal. So you've got the external oblique ridge somewhere here. On this one, we can see the external oblique ridge on that one. But then we see something very particular. And these patients have got very distinct submandibular gland fossae, which means the lingual surface of the mandible is very hollow or very concave. So this is what they have, very pronounced submandibular gland fossae. We've got another patient here. He's 37 years old. He smokes cigarettes. He's got some COPD. He's got GERD as well. Tooth number 47 was extracted several months ago, and so we take a panoramic X-ray, and this is what we find. And I'll let you have a glance at this one, but try to identify the anatomical landmarks first. So when you're looking at the maxilla, this is the posterior border of the maxilla. This is the floor of the maxillary sinus. And look how far this goes. This goes almost to the midline. Same thing on the other side. You can see the maxillary sinus all the way up there. There's a nasal cavity. You've got the nasal septum. There's the floor of the nose or the hard palate. So we can see that this patient has hyperplastic maxillary sinus. It's got huge spaces in his humongous maxillary sinuses. It's got periodontal disease as well. We notice that as well. And the alveolar socket is not healing well on the 4-7. So you better check a couple of things clinically as well. But radiographically, this patient has very huge maxillary sinuses, which may be a problem if you're trying to solve this periodontal issue with implants in the long run. It will be very difficult to place implants. We've got another case. We can see maxillary incisors, and you try to identify what is going on. They are pretty radiopaque, and you identify that this might be a supernumerary tooth, and there might be another supernumerary tooth. There's the permanent incisor, there's a permanent incisor, and then you've got tooth number 5-1, 6-1 still in place. And this is an incidental finding, right? So you identify there might be a mesiodens or double mesiodens in this case, but you might be looking at a macrodont, two macrodonts, in fact, for 1-1 and 2-1. So how will you identify if you're looking at two separate entities, or if it's just one big tooth? Well, there's a solution. You can take an additional periapical radiograph coming from a little bit more from position of tooth number 1-2, and you can do the same thing coming more from the position of tooth number 2-2. And now you can see that this one here has moved that direction in your image, and that supernumerary has moved in that direction. So it's separate from tooth number 1-1 and separate from tooth number 2-1. This is called the parallax technique. Parallax. Or you can use another word, which is that should be L. Slop rule, same lingual, opposite buccal. So when the X-ray machine moves in this direction and the tooth moves in the same direction, it has to be on the lingual. And then you can do the same thing on the opposite side, so you don't really need three-dimensional imaging. You can just use two periapicals to look at the position of a tooth that is hiding. So we've got two palatally impacted supernumerary teeth. In this case, the surgeon decided before the surgery to go and take a cone beam anyway, because he needed that information, he said. So for him, the justification principle was simple. I'm not cutting into this patient unless I know where those additional teeth are. So he took this cone beam CT image and identified the two supernumerary teeth, but forgot to look at the entire volume and removed the supernumerary teeth, but he forgot to look at this one. And this is just a plea to stress the importance of looking at the entire volume. Although you might be interested only in the anterior region, you have to look at all the teeth that are involved in this cone beam CT image. So there was more than just two supernumerary teeth. There was also a supernumerary tooth between the lower lateral incisor and the canine. Let's have a look at CBCT image from another patient, and I've put these letters on the cone beam image. So we are looking at an axial view, we are looking at a frontal view or a coronal view, and we're looking at an axial view again. A is part of the sphenoid sinus, C is part of the sphenoid sinus, B is the space between the sphenoid bone and the back of the maxilla. So we are looking at the pterygomaxillary fissure. D is the middle nasal concha. This is the inferior nasal concha, the middle nasal concha, and the superior nasal concha will be a little bit higher up. And then E and F are very interesting. E and F are the maxillary sinuses, and you can identify immediately the difference between the right-hand side sinus and the left-hand side sinus. The left-hand side sinus is completely obliterated. This might be just mucosal hypertrophy or irritation in the maxillary sinus. In some areas in the world, you can see this much more often during the winter time or when patients are going through a cold, for instance. G and H, G is pointing at the coronoid process of the mandible, and then H is here on the medial pterygoid plate of the sphenoid bone, where the hamelin notch is attached to as well. So we've got medial pterygoid plate, lateral pterygoid plate, and the scaphoid fossa there for the lateral pterygoid muscle. So here you can see them again. So the sphenoid sinus, pterygomaxillary fissure, the sphenoid sinus again for C, middle nasal concha for D, E and F are the maxillary sinuses, G is the coronoid process, and H is the medial pterygoid plate of the sphenoid. We've got another case here. We've got a patient that had an implant placed, and this one was placed well, but then things went a little bit wrong, and the second implant was suddenly, or was not, when the second implant was placed, it suddenly disappeared into the spongy bone. And when you look at these cone beam CT images, there should be something that is very obvious to you, and it's the fact that there is hardly any trabecular pattern in the spongy bone. So when the surgeon was looking at the slices on the cone beam, he probably just looked at the continuity of the cortical bone of the mandible, tried to identify the mandibular nerve, which is quite difficult in this case because this patient doesn't have a corticated mandibular canal. They identified the mental foramen and then sliced it all up into 2mm slices and decided we're going to place an implant here and we're going to place an implant there, and then they forgot to look at the trabecular pattern. So it's very important not just to look at the amount of bone that you have available, but also the quality of the bone, and that is something that cone beam will actually be able to do for you. So here you can see the anterior part of the mandible, and you can see trabeculation in the spongy bone, whereas in this area there is barely any trabeculation that you can see. So it's no wonder that the implant disappeared, and the implant was very, very close to the mandibular nerve, but they were able to retrieve it. Here you can see another example of the use of cone beam CT in case of an accident, which was not a very good idea. And I'm trying to explain to you that when you look at these images, this is the sphenoid sinus, and it's not radiolucent. These are the maxillary sinuses, and they're not radiolucent either. I can see a little air bubble there. I can see some frothy air there as well. But this patient was in an accident. Patient broke the jaw, had coronoid fracture, had body of the mandible fracture, had a condylar, bilateral condylar fracture as well. You can see them here in the coronal views. This is not a good indication for cone beam CT, especially not immediately after trauma, because cone beam CT will not be able to tell you if that and this is not blood. If this patient is bleeding internally, or if there's any brain damage, you will not be able to tell that on a cone beam CT. So this would have been much, much smarter to place the patient in a medical CT. And then we go to justification. If you can justify the higher exposure, then go for that. Because in this case, you might be overlooking very severe internal bleeding. So multi-slice CT or medical CT would have been a much better choice. I think we're running out of time. It's about an hour far now. I will just show you quickly, when you're looking at x-rays, try to look for anatomical things. Here you can see what we call a ponticulus posticus or a foramen arcuatum on C1 for the vertebral artery that passes through. But I think we're running out of time. Unfortunately, once I get carried away, I start talking and I forget about the time. So I apologize to the audience for not being able to finish all my slides, but I would like to thank you very, very much for your kind attention. And if you would have any questions or if you would have any comments, please do not be afraid to email me. I'm pretty sure the organizing committee will take care of some questions as well. And thank you so much for your very kind attention.
Thank you, Johan.
My pleasure. Thank you, Ami, for the opportunity.
Thank you, Dr. Dan Johan Epps, for delivering very interesting material. Ladies and gentlemen, that is the presentation of the material that has been presented by the presenter today with the title Dental Radiography in the General Dental Practice. Next, we will open a question and answer session. Questions are asked through the chat column using English briefly, concisely, and clearly. Okay, Dr. Johan, it's first question from Rida Aulia Rahmah. Excuse me, I would like to ask a question to Dr. Johan, but it seems like easier to ask directly to him than through the chat column. So could I ask it directly to him? Thank you. Okay, please, Rida Aulia Rahmah.
Okay, I would like to say thank you for the opportunity so that I can ask a question to our amazing speaker today, Dr. Johan. So I would like to ask a question based on the table about typical effective doses for dental and medical diagnosis exposure. As we can see there are so many different effective doses based on the technique that we will use, such as bite wing or panoramic radiograph or upper standard occlusal. So my question is, what happened if the operator use more than from the effective doses or less than the effective dose? What's the effect to the result of our picture radiograph, or is there any effect to our body health if the operator use more than or less than from the effective doses? Maybe that's my question. Thank you.
I'm not sure if I understand your question correctly, but I think your question is if you would increase the radiation dose, what is the effect for the patient, right?
Yeah, increase or maybe decrease
Yeah.
from those.
So, yeah, okay. So when you're using your X-ray equipment, you can choose or you can change the kilovoltage. You can change the milliamperage on your machine, and you can change the exposure time. If you increase the milliamps on your machine, you will increase the radiation dose. And there's a linear relationship between that. If you increase the exposure time, you will increase the radiation dose as well, because there's also a linear relationship between the radiation time and the radiation dose. For kilovoltage, it's not linear. It's a much more complicated calculation you have to make. So I guess your question is more like, what happens if I make a mistake and I expose the patient too much? Will it have an effect on the image quality? If you increase the milliamperage, the image quality will be increased as well. You will get much, much better images. But if you increase the milliamps, I just said you will increase the dose. So there's a limit to which you can increase the dose to increase your image quality. You should actually invert the question and say, how low can I go with my milliamperage? How low can I reduce, how much can I reduce the radiation dose in order to still have a reasonable and diagnostic image? And that's the Allardyce principle. You can reduce the dose to a certain level where the image is still diagnostic. Once you reduce the dose even further, your image is no longer diagnostic. And so, for instance, if you would take a cone beam CT image on a patient and you think, oh, I will reduce from 6 milliamps to 3 milliamps, you will see that the image becomes much more grainy. There's more noise in the image. But if you would go from 6 to 12, for instance, you will increase the dose, you will double the dose to the patient, but your image will become very, very nice. The question then is, can you still make the same diagnosis? Right? So if the 3 milliamperage or the 6 milliamperage or the 12 milliamperage gives you the same diagnostic information, you should try to stick to the 3 milliamperage because you have reduced the dose considerably for the patient and you've kept the diagnostic quality at a very high level or an acceptable level. Is that an answer to your question?
Yeah, thank you, Dr. Johan. I got it.
Thank you. Thank you for your very interesting question. It was not an easy question to answer.
Thank you.
Okay, next question, Dr. Johan. I would like to ask a question, doctor. What is CBCT actually used for? In what condition we have to use CBCT? I mean, as far as I know, at this moment, CBCT is also used in endodontic. Thank you very much.
Yeah, that's a very good question. And I think it's the answer is pretty simple. It all comes down to justification. If you can justify the higher radiation dose exposure to your patient, then you can use cone beam CT. But you should not be using cone beam for every case. When you look at the literature, cone beam CT should only be used to help you with your diagnosis if two-dimensional imaging is not giving you sufficient information or is not helping you enough. The reason why they use it in endo is because it allows you to identify additional canals. For instance, in an upper molar, you may find the NB2 canal much easier. For implant placement, cone beam can definitely be used because you will be able to identify the bone volume in all 3 dimensions. So that's good. It can help you identify fractures in teeth. It can help identify fractures in jaws. And I think for those cases or for large pathology where the pathology is still within bone and around teeth, cone beam is definitely a good way to identify the real and the exact extent of the lesion. But it should not be a routine thing. I may have shown you a couple of cases where you might think, oh, this is routine in some countries, but it should not be a routine thing to take cone beam. The standard is still two-dimensional imaging.
Okay, Dr. Johan, it's another question.
Yeah. Is that the one about children?
Yes, I'd like to ask a
Radiography.
question from Sheila Suhaila Matondang about CBCT. Can CBCT radiography be used for children? Thank you, doctor.
But as I said before, it has to be indicated, right? So the indication must be respected. The problem with children sometimes is that they cannot sit still long enough, and then it's very difficult to get a good image. When I think the majority of pediatric cases will be trauma, dental maxillofacial trauma. But if it's a simple dental trauma, usually two-dimensional imaging will be more than enough. There's a couple of indications where cone beam can be used. For instance, supernumerary teeth, wisdom teeth extractions, especially in the lower arch. But I think in pediatric dentistry, that's about the majority of indications you can find: trauma and supernumerary teeth, eruption issues, and extraction of third molars, for instance.
Thank you, Dr. Johan. And can I ask?
Yeah, of course. Yes.
Okay, it's about mobile radiography. Yeah, because he talked about dental radiography in general dental practice. Yeah, can it be used in private practice? And if it can be, and what are the requirements?
I think the beginning of your question was about mobile radiography?
Yes.
I'm not familiar with the situation in Indonesia, but when you say mobile, you mean handheld devices?
Yes, the radiography, it can be used to other room. Jadi room.
Oh yeah.
Yes.
Yeah.
Yes.
So it's like a portable X-ray machine, like the Nomad, for instance. In some countries they are forbidden, and in other countries they can be freely used. I know that. In the United States, for instance, they are freely available and everybody can use them. In other countries, they're very restricted. The problem with portable machines is that the operator, the person who is operating the machine, should be protecting themselves because there's always backscatter from the patient. Once you expose the patient will scatter the radiation. And so you have to protect yourself. And if you're doing that on a daily basis and you are exposing yourself as an operator very often to that kind of radiation, you're actually running a high risk to develop a cancer. So I think it would be very wise to protect your thyroid gland. And if you're a woman, you should definitely be wearing a protective apron. Not saying men should not be protecting themselves, but be very careful with the scattered radiation. It's not the radiation coming from the machine itself, because that's pretty safe. That's been proven. There's no leaking radiation from the machines, but it's the patient's scattered radiation. And that's why you have to keep distance from the patient as well. So I think the answer is yes, you can use portable X-ray machines, but you should be protecting yourself as an operator. Yes.
Okay, to all participants, any question? Any question, please?
Which is better, CT or CBCT, and what is the disadvantage? Okay.
Yes.
That's a good question. That's a very good question. Medical CT or CT will allow you to use Hounsfield units, and Hounsfield units allow you to identify different radiopacities in the images. So you've, as I showed you that example with the patient that had the accident, with probably hematoma in the sphenoid sinus or in the maxillary sinus, if they would have used medical CT, they would have been able to identify if the fluid in or the radiopacity in the sinuses was blood or merely mucus, or if it was more of a watery consistency. So medical CT allows you to identify much, much more. Cone beam CT is especially ideal for teeth and bone. So it all depends on the indication. If you're dealing with a process or a pathology that is spreading from the bone into the soft tissues, then medical CT would be much better. If you're looking at a process that's confined to bone only, then cone beam CT will do the trick. But you cannot distinguish soft tissue as well on cone beam CT as you can do on CT. So I hope that answers my colleague's question.
Okay. Any question to all the participants?
Let's see. Nothing coming in.
I think that's enough for the question, Doctor.
Okay, thank you so much.
Okay. Okay, ladies and gentlemen. Yeah, that's what this webinar is about, dental radiography in general dental practice. Before we end this session, I will try to conclude the result of this seminar, namely the use of dental radiography in general dental practice can be done while still prioritizing the safety of the operator and the environment by providing radiation protection to the operator and the environment. Ladies and gentlemen, once again, we would like to thank the presenters and also all the attendees who have participated in his webinar. Finally, as the moderator, I resign. Hopefully, we can meet again in another webinar. Thank you. Wabillahi taufiq wal hidayah. Assalamualaikum warahmatullahi wabarakatuh.
Thank you.
Thank you very much, Dr. Johan Apps and Dr. Gigi Cekdaramanja for your amazing, inspiring presentation today. Now, the certificate for this session will be given by Dr. Gigi Ami Angela to Dr. Johan and Dr. Gigi Cekdaramanja.
Dah Johan, on behalf of our rector, we would like to give you our appreciation because you are willing to do this seminar. This is the certificate, and we hope, we can further working in collaboration with our university, Universitas of Sumatra Utara. I would like to thank you and to give you applause for your.
Thank you, Ami.
Thank you very much. And
all right, thank you so much for the opportunity. I'm very honored. Thank you.
And for the moderator, Dr. Cekdaramaja, in the name of Dean, because our Dean have a meeting, and I give you the certificate for you as a moderator today. You have done a good job and a wonderful job. Thank you very much. And I give back to the MC. Thank you.
Thank you very much. Ladies and gentlemen, we would like to remind you, for those who still hasn't confirmed their attendance, please fill in the Google form in the chat box. This will be the end of the second session, and we are having another break again. As a reminder, we will be continuing the third session at 2:45 p.m. Again, all the participants are advised to attend the third session 10 minutes early. Thank you for your attention. See you again in the last session.
North Sumatra, a sign of God's love given with full affection, a piece of heaven attached to the earth, home of the world's largest ancient volcanic lake that holds 1,000 legends and mysteries, a land for diverse cultural conformity where civilizations live in harmony, a place of dignified tolerance where the seeds of hope are planted, grown, and reaped for prosperity. The genuine miniature of Indonesia.
By declaring the tagline transformation towards the ultimate, Universitas Sumatera Utara is ready to transform into an international standards university with excellent local characteristics. I am Murianto Amin, presenting you Universitas Sumatera Utara.
Starting from Universitas Sumatera Utara Foundation, which collected moral and material support from the people of North Sumatra and Aceh. On August 20th, 1952, the Faculty of Medicine was successfully established. USU was inaugurated as the 7th state university in Indonesia by the first president of the Republic of Indonesia, Sukarno, on November 20th, 1957. Located in Medan City, North Sumatra, USU consists of 2 campuses located in Jalan Dr. Mansur and Kuala Bekala. USU has 15 faculties, 1 graduate school with 163 study programs, and 1 experimental garden covering an area of 300 hectares located in the Tambunan area, Langkat Regency. USU has the vision of becoming a university that has academic excellence as a barometer of scientific advancement that can contend in the global world. Carrying a new spirit, transformation towards the ultimate supports the entire USU academic community to make significant changes to their mindset and work culture per the demands of bureaucratic reform and technological acceleration. Transformation towards the ultimate is indicated by a series of transformations in various sectors. The transformation is realized through collaboration and synergy between the academic community and various parties to create excellent higher education services implemented through Tri Dharma. Campus digitization is an absolute must to provide the best service. Various digital services are provided by USU, such as ASA, e-office, e-agenda, PPID, and also telemedicine. Telemedicine provides easy access for medical treatment to the public through their gadgets. USU has received an A accreditation and is included in Cluster 1 of the Indonesian Ministry of Education and Culture 2020 rankings and ranked 15th university in Indonesia by the Times Higher Education Impact Rankings. USU has also established itself as a part of the international education community. USU is ranked first nationally and ranked 305th in the world in the field of agriculture and biological science at the university level by the Skimago Institutions rankings. In addition, USU is ranked 1201 plus in the world with QS Stars 3 on the Quacquarelli Simmons World University Rankings 2022 rating agency. As a commercial university, USU is committed to encouraging research to create an USU enterprise by establishing the Institute of Innovation and Business Technology Incubation, or LINKS. Links is a place for innovation and research products of USU's academic community to make contributions to society. Some of these innovative products are being prepared for mass production by cooperating with the industrial world and other universities as the implementation of the Merdeka Belajar Campus Merdeka program. Merdeka Belajar Campus Merdeka program is a manifestation of learning by combining theoretical and practical aspects to create excellent human resources. USU collaborates with various partners, from the state-owned company to the government sector, with the aim of creating graduates who are ready and able to follow the needs of the industry and the market. To support comprehensive learning, USU provides integrated facilities. Various facilities available include USU Hospital, Dental and Oral Hospital, Integrated Laboratory, Student Workshop, Auditorium, Student Center, Pancasila Building, International Guest House, Cafeteria, Student Dormitory, Garden, and various sports facilities.
The spirit of transformation towards the ultimate within the scope of the Tridharma is a manifestation of USU's commitment to produce excellent human resources for the advance of Indonesia.
USU believes that the contribution of all parties is the main key in the effort to transform to be superior. USU, the pride of North Sumatra for Indonesia, transforming to be the best in the world. North Sumatra, a sign of God's love, given with full affection, a piece of heaven attached to the earth, home of the world's largest ancient volcanic lake that holds 1,000 legends and mysteries, a land for diverse cultural conformity where civilizations live in harmony, a place of dignified tolerance, where the seeds of hope are planted, grown, and reaped for prosperity. The genuine miniature of Indonesia.
By declaring the tagline transformation towards the ultimate, Universitas Sumatera Utara is ready to transform into an international standards university with excellent local characteristics. I am Murianto Amin, presenting you Universitas Sumatera Utara.
Starting from Universitas Sumatera Utara Foundation, which collected moral and material support from the people of North Sumatra and Aceh, on August 20th, 1952, the Faculty of Medicine was successfully established. USU was inaugurated as the 7th state university in Indonesia by the first president of the Republic of Indonesia, Sukarno, on November 20th, 1957. Located in Medan City, North Sumatra, USU consists of 2 campuses located in Jalan Dr. Mansur and Kuala Bekala. USU has 15 faculties, 1 graduate school with 163 study programs, and 1 experimental garden covering an area of 300 hectares located in the Tambunan area, Langkat Regency. USU has the vision of becoming a university that has academic excellence as a barometer of scientific advancement that can contend in the global world. Carrying a new spirit, transformation towards the ultimate supports the entire USU academic community to make significant changes to their mindset and work culture per the demands of bureaucratic reform and technological acceleration. Transformation towards the ultimate is indicated by a series of transformations in various sectors. The transformation is realized through collaboration and synergy between the academic community and various parties to create excellent high education services implemented through Tridharma. campus digitization is an absolute must to provide the best service. Various digital services are provided by USU, such as ASA, e-office, e-agenda, PPID, and also telemedicine. Telemedicine provides easy access for medical treatment to the public through their gadgets. USU has received an A accreditation and is included in Cluster 1 of the Indonesian Ministry of Education and Culture 2020 rankings and ranked 15th university in Indonesia by the Times Higher Education Impact Rankings. USU has also established itself as a part of the international education community. USU is ranked first nationally and ranked 305th in the world in the field of agriculture and biological science at the university level by the Skimago Institutions rankings. In addition, USU is ranked 1201 plus in the world with QS Stars 3 on the Quacquarelli Simmons World University Rankings 2022 rating agency. As a commercial university, USU is committed to encouraging research to create an USU enterprise by establishing the Institute of Innovation and Business Technology Incubation, or LINKS. LINKS is a place for innovation and research products of USU's academic community to make contributions to society. Some of these innovative products are being prepared for mass production by cooperating with the industrial world and other universities as the implementation of the Merdeka Belajar Campus Merdeka program. Merdeka Belajar Campus Merdeka program is a manifestation of learning by combining theoretical and practical aspects to create excellent human resources. USU collaborates with various partners, from the state-owned company to the government sector, with the aim of creating graduates who are ready and able to follow the needs of the industry and the market. To support comprehensive learning, USU provides integrated facilities. Various facilities available include USU Hospital, Dental and Oral Hospital, Integrated Laboratory, Student Workshop, Auditorium, Student Center, Pancasila, International Guest House, Cafeteria, Student Dormitory, Garden, and various sports facilities.
The spirit of transformation towards the ultimate within the scope of the Tridharma is a manifestation of USU's commitment to produce excellent human resources for the advance of Indonesia.
USU believes that the contribution of all parties is the main key in the effort to transform to be superior.
Ladies and gentlemen, welcome to the last session of Top Scientist Webinar World Class University. We would like to remind you, for those who still hasn't confirmed their attendance, please fill in the Google form in the chat box. Now, we will continue the last session, a presentation from Professor Dr. Nicola M. Grande, DDS, PhD from the Catholic University of Sacred Heart, Rome, Italy, and will be moderated by Dr. Gigi Denis, MDSC, SPKG Consultant. Dr. Gigi Denis is currently pursuing his studying in PhD at Thammasat University, Thailand, and a lecturer from Conservative and Endodontology Department, Faculty of Dentistry, University of Sumatra Utara. I will be handing over the last session to the moderator, Dr. Denis, when you are ready.
Thank you very much for the MC. I wish each and every one of us a very good afternoon. It is the last session of the Top Scientist webinar today. And for this session, we will have our top grade endodontist, Prof. Dr. Nicola Grande. But before, I would like to read his curriculum vitae. Dr. Nicola Grande received his degree in dentistry from the Catholic University of Sacred Heart in Rome, Italy, and in 1999 with a degree thesis on the fracture of nighttime rotary instruments. After 2 years in the Department of Endodontics at the same university, he served as an assistant professor in endodontics from 2001 up to 2009. In the year 2002 up to 2008, he has been professor of endodontics in the School of Dental Hygiene. From 2009 up to 2013, he has worked as researcher in the Department of Endodontics at the University of Roma La Pienza. He completed his PhD program at the Catholic University of Sacred Heart in 2009 with a thesis on an innovative technique for the restoration of endodontically treated teeth that he has invented. Presently, he is a professor and chair of endodontics at UCSC. His main scientific interests are the preparation of root canals with nickel titanium rotary instruments, the study of anatomy and preparation of endodontics and anatomy by microcomputed tomography techniques, and the restoration of the endodontically treated teeth with new conservative approach. He contributed in the development of different instrument systems and new techniques, and he is holder of different international patents in the field of dentistry. He is certified member of the European Society of Endodontology, ESE, and the American Association of Endodontics, an active member of the Italian Society of Conservative Dentistry, and of the Italian Academy of Endodontics. And now he has been elected as the forthcoming president of Italian Academy of Endodontics for the years 2022 to 2023. Dr. Grande is member of the editorial board for the major international journals in endodontics field. He has published extensively in the international peer-reviewed journals, where he has more than 100 papers published with high impact factors. In 2021, his H index is 44, and he has more than 1,500 citations. He lectures since more than 15 years, both nationally and internationally. Now he's working as specialist of endodontics and microsurgery in his own private clinic in Rome, Italy. I'd like to say hello to Dr. Nick Grande. I wish you a very good afternoon and good morning in Rome.
Hi.
Italy.
Hi. Good morning.
Hello.
Good morning.
Nice to meet you. Without further ado, I would like to give this time to Dr. Nick Grande to share and to deliver your lecture. And now the time is yours. Thank you very much.
Thank you very much, Dennis, for the introduction. I'm really proud to be here in this worldwide class of endodontics, and thanks for the invitation. And yes, I would like to be there, not in virtual Congress, but we hope in the future we could do it again. And so here we are early in the morning in Italy, and we are starting the day like this. For sure, pandemic we will learn from this pandemic moment that even there are new opportunities to collaborate and to share our experiences even better in a distance way, like we are doing this morning. So thank you very much again. And my team was about the minimal invasive approach in endodontics. I shared the screen in the meanwhile. That is something that is becoming a really interesting argument, because in all the fields of dentistry we are seeing that this is the new trend, and we will go through the analysis of what does it mean in endodontics minimal invasive. But I want to start from what is in the last times my philosophy and what we are following as a philosophy in our practice. It is this concept that less is more, and less is more is a phrase that represents the approach that we should have in front of our world in general, but we can have it even in front of our profession. And it started by the first concept started with an Italian painter in the medieval era, but it became famous when an architect that was Van der Rohe diffused the concept that the less we do, the better it is. And of course, today we can accommodate this term with another concept that is the concept of sustainability. That means that we can do something for everybody, and that these things does not create damages for the other people and for the future of our world, even when we will not be here more. So the concept of sustainability, it is applied, of course, in our general life, in all our life, because when something is not sustainable, people and nature will suffer today and in the future, and probably we will risk that this will lead to something that it will be really, really bad for all the humanity. And we know that the amount of the population is growing up day by day, and that in our field, our pathologies are really the most diffused, not healed. So there are a lot of dental and endodontic pathology that are not at all considered as pathology in the world. So many people, they cannot sustain their own therapies, and this is well diffused everywhere in the world. So the recommendation of the World Health Organization, that should be the say who is organizing how to do our practice in general in all the world, one of the recommendation, it is that the therapies, they should be sustainable. Therapies should be possible for many people, so not cost effective, not too expensive, and faster, cheaper, So the minimal invasive concepts join this, and in many fields of the medicine, the increase of minimal invasive treatment is evident in the last years. So in many different fields, what we are seeing it is that the minimal invasive procedure, they increase a lot in the last years, in the last decade, while the invasive procedure that are more expensive, time-consuming, and not applicable for many people, they are decreasing a lot. So the trend is going through this. And what we would like to see in the future, it is that the technology that is something changing our practice and our life will be diffused not only to increase our quality, that of course it is really important. So we have to use our microscope and to do better endodontic treatment, but even we have to use our technology to increase the sustainability of our treatments. So to make our treatment easier for more people in the future. So when we come to the minimal invasive dentistry procedure, we see that this is not something that we can define precisely with a technique, okay? It is not something that we can describe as a sequence of nickel titanium files. This is something that has to be introduced in our practice and in our mind as a philosophy, as a way to do it in the daily practice, in general, in all our mechanism of relationship with our work, and even in our direct practice on the patient. For example, sometimes in young patients, we observe these situations. This was a tooth that was not painful, so with a big lesion in the occlusal surface. The patient is really young and without the apex still not completed in the second lower molar. And we see that there is a big decay, but the patient disappears and she comes back only when she has pain. And we see that there is even an involvement of the mesial root about the periapical pathology. And we see that to apply the concept of, minimal invasive, we didn't treat the root canals because of the age of the tooth and because the pathology was still confined in the dental pulp chamber. And we did a pulpotomy. That is a cheaper treatment that achieve the same results of a complete root canal treatment. And in this case, there was the indication to do this kind of treatment. So even this is an approach that it is really conservative and minimal invasive because it is really cost effective and fast, and we don't need so much instruments and materials to do this. We just need a rubber dam to isolate the tooth and make the treatment completely sterile. This is really important. And the rubber dam is something that should be diffused everywhere and to do many therapies that usually they are made without. Another example of an approach in which this tooth was treated with an endodontic that for sure is not minimal invasive. This is an old treatment, and the approach was a normal approach with a coronal shaping that is well represented. But when we go to do the restoration, we are working with a minimal invasive treatment of the bone tissues. So when we come to the periodontology, already we apply some techniques that require only a small amount of bone cutting, because this is much more sustainable, and in the future the tissue we will be better for the other teeth too. While in the past the surgery for periodontal reason, it was wider and wider. We just remove the bone where it is needed to place our restoration. We take the impression during the surgery to contract the time and make lower the price of the treatment. And after 1 week, when we go to remove the sutures of the intervention, we can cement our overlay, that in this case is lithium disilicate, but it can even be something that we do on our chair side with CAD/CAM procedure. And this is a restoration that is well accepted in the oral cavity, and it doesn't create the destruction of a lot of tissues in the mouth. And we see that even the result in terms of periodontal integration and anatomical integration is really good. So another concept, it is that restorations and treatments that lost a lot in the time, it is important because they are more sustainable, because we do one time and they last for a long period. This is something that should be considered. So coming to the minimal invasive dentistry, and in particular the minimal invasive in general in our approach to our profession, this from one of the articles that described first this kind of approach, it is a systematic respect of the original tissue. So for sure, when we respect the natural tissues of the patient, we are applying this concept. So we pass from general minimal invasive dentistry to minimal invasive endodontics. And of course, we have to be smart to think with both the sides of the brain to choose the right procedures for the respect. And when we start our treatment with a coronal access, it is the first thing that we have to analyze, how to do this access, how to do our approach to our teeth. And usually, when we cut the teeth, we do it because of the restoration that we want to do. So my suggestion is always to consider, before to start the treatment of endodontics, to consider which is the restoration that we want to do. Because in this way, we can drive our access in a better direction or more comfortable approach. So when we take a look in the restoration of endodontically treated teeth, there are many articles in the literature, more than 1,000, but there are few answers on how we have to treat these teeth, how we have to restore these teeth. And if we look to this Cochrane review, that is no more than 10 years ago, but it's not so old, and we see that there are many studies, because in the review they were comprised of many studies, and I have to underline that this is from 2012. But if we do the same meta-analysis in 2021, we will find the same results. And this is the conclusion of the authors, that until more evidence becomes available, clinicians should continue to base their decision on how to restore filled teeth on their own clinical experience. So this means that we have no answer about how to do a restoration in our root-filled teeth, because we have to base our approach and our procedures on what we think is better from our clinical experience. So when we go inside the concept of when we access a tooth, how we have to cut this tooth, how much we have to remove, we take a look on what happened in the teeth when we remove a portion of the tooth, and what happened to a tooth when we treat, when we remove the pulp in this tooth. One first important article, really simple, but it's really important, is this article in which they compared 23 pairs of teeth. They were treated in the mouth on one side 10 years before, and the contralateral teeth, they were sound, they were vital. So they extracted these teeth for orthodontic reason, and they compared some mechanical features of the tooth, of the dentin once it is extracted. Because we have in the mind the concept that the dentin of the root canal treated teeth is more brittle and more delicate than the dentin of a vital tooth. But this is something that is not true, because they found that any significant difference was found in the mechanical properties of the dentin, of the tooth, of the teeth that were treated 10 years before, or the teeth that were vital. So this is something that is really noticeable, because in our practice, usually we consider the root canal treated tooth something that is brittle and not as affordable as the teeth that we have vital. Un second. Mi metto di là così non faccio. There. They considered how much the tooth stiffness were influenced by the procedure of cutting dentin inside the tooth. And so they considered the stiffness of the tooth. And they saw that when we do a small cavity access in the tooth, we have a reduction of the stiffness of the tooth of 5%. So when we do a small hole in the coronal portion of the tooth, or a really contracted cavity, the tooth is similar in its mechanical behavior as a regular tooth. When the occlusal surface is more damaged by our cavity, the stiffness of the cuspal deflection, it is 20%, 15% less. So we lost from 5% to 20%. The other consideration it is that when we lose the marginal ridges, we arrive to lose the 63% of the cuspal stiffness, and cuspal deflection increase a lot. So the tooth can break more easily for the same pressure. So this is important because in general, the golden rule, it is linked with the minimal invasive concept. The more we leave the tissues of the patient in the tooth when we prepare for the cavity access, the better it is. And this is something that, from a mechanical point of view, helps the tooth to be stronger and to live longer in the life of the patient. Okay, so to avoid problems like fractures and highly cost-effective and less cost-effective restoration, as implants, that they are a really good solution, but if we can avoid, for us, it is a better situation. So the myth that we have in the cavity access is the straight line access. We want to go inside the root canals with a straight line starting from the occlusal surface that arrive with a convergent walls in the root canals. And this is something that has been written in the books for a long time, and all the textbooks of endodontics, they were describing the cavity access in this way, like something that should visualize really good the floor of the cavity, and the classic concept to visualize in a single shot all the root canals in the same view. So what we did in the past was to cut the cavity access starting from the occlusal surface with a predefined shape. So we knew that the root canals are under those parts, and we arrived to the pulp horns, we enlarged the cavity, and finally we find the root canal that we see from the top with a good hole in which we see 1, 2, 3, and 4 MB2 root canal in this upper molar. But as you see, we designed the cavity from the top to the bottom in the same time. So this kind of approach today is a little bit wrong, okay? Because we called this kind of cavity a sumo axis, a big axis that sometimes is not required, okay? So following the concepts that we already explained of minimal invasive approach to our profession, these two authors, almost more than 10 years ago, proposed an approach that doesn't follow the straight line concept. So they propose a new way to open the cavity that doesn't permit to see all the root canals in the same time, but you have to move your microscope or your head to see the different root canals, so that the cavity is a little bit smaller and we leave the wall of the tooth bigger. So this is the first article describing an endodontic cavity following the principle of minimal invasive. Before this article, this kind of access, they were considered completely wrong because we had to have a straight line access, okay? And this was true even because we had different instruments, and we have to consider that this changed. The other concept that it is really well followed, and still it is something that is followed in endodontics, is the early colonal enlargement, described by Raddle, in which we enlarge before the coronal portion, and then the apical one, then the medium, and then the apical one, because so we are easier in arriving to the working length, and we are easier in preparing the apical portion of the teeth. But when we do this enlargement on the coronal portion, sometimes it is not needed, okay? So the early coronal enlargement is indiscriminate removal of the coronal interferences, because sometimes, of course, there is an interference, but the root canal is easy. We arrive easy in the apical portion, and so we don't need to cut the portion. This is what I mean with early coronal enlargement. We cut all these interferences of the access to the root canal, and what it is happening, it is that we make the root canal wall really thin. We make the root canal wall smaller, thinner, okay, as you see here. So sometimes it's needed to remove this portion, sometimes not. So what we are changing is that we do these things only when it is needed, only when it is mandatory to arrive in a really particular case, in difficult cases. So we make something that it was made all the times, we transform in something that is made only when it is needed. So it is selective, no more indiscriminate, okay? So the indiscriminate, it is to make all the teeth the same and to create a damage in the tooth in all the situations, even when it is not needed. So this was what clinically we can see as our classic approach. We open a big cavity access with a convergent walls. We can see all the root canal in the same time. We enlarge a lot the coronal portion of the root canal to create, with the early coronal enlargement, a straight line access to our root canals. You see that the instrument goes straight from the coronal portion to the apical third. This is something that is really comfortable for our treatment. It is comfortable for our instrument to arrive directly in the apical third, but we pay something in terms of loss of tissues, in terms of tissue sacrifice that we create in this area. And we will see that this area, it is the most important for the mechanical resistance of the tooth. The old instruments, they were designed to create this big opening, okay? These are the instruments that are more diffused in the world, and they start with a big file that is small in the tip and really fat in the body, so that we can enlarge with what was called Tour-Eiffel shape, creating by purpose what we were doing before with the Gates Glidden burst, that is a coronal enlargement to make easier in all the cases the treatment of the apical part, that of course is the crucial part of the treatment, the most dangerous, and for our success. But this kind of approach goes to remove what we consider the most important part of our tooth, that is what we call the pericervical dentin. The pericervical dentin, it is the tissue, the hard tissue that goes from the cement enamel junction 4 millimeter up and 4 millimeter down, and it is considered even in the thickness that is really important. So it is what was before called ferro, but it is considered in three-dimensional approach. So this is what we call pericervical dentin. The thickness and the height of this portion of the tooth will give stronger results in terms of mechanical resistance for any kind of restoration, for the crown, for the tabletop, even for a direct restoration. The tooth is stronger when it has that part thicker and higher. And so we struggle to keep that area as much as possible, because we want, even in difficult case, not to have the straight line access as much as possible, but we want to keep as much as possible that area that is called pericervical dentin. So I underline, it is not important to make a small hole up on the top of the occlusal surface. That is not so much important. It is important to keep this thickness, that is the pericervical dentin. Okay? We see here that there is an undercut that in the past was considered wrong, not a good thing, today, if you leave an undercut with a pulp horn in the bottom of the undercut, this is not a fault, this is not wrong, and we have the possibility to treat that area. We will see how we do it. The most difficult teeth, in my mind, are not the molars, but the lower incisors. There is a little bit of rumor on the background. Probably there are some microphone open, if you can check to shut off. And so the most difficult teeth are not the molars, in my opinion, but the small lower incisors. The lower incisor is a small tooth, and when we have to prepare the apical area, I think there is a microphone open, and there are background sounds that can you shut off the microphones? So that when you have to treat the apical area and you have to keep this thickness of dentin, is really difficult because the tooth is really small. So this part of the tooth was maintained because this teeth, to keep this pericervical dentin is really difficult. And it can, sorry, there is a sound on the background. Can you shut off the microphone, please?
For all participants, I ask to make mute mode for the microphone. Thank you.
Okay. So something that we used in the last years to improve the keep of the coronal portion of the tooth, so of the pericervical dentin, it is the variable taper of our files. Because when we have a variable taper in which there is a higher taper in the apical region and lower taper in the coronal portion, okay, so not a constant taper, taper 4, taper 6, taper 8, but a variable taper, we can have an instrument that can cut where it is not important about the mechanical resistance and keep the dentin smaller in where it is important to keep it. Another important thing that we changed was the use of a single file, because when we use a single file, we stamp the shape of the file, that possibly it is even a variable taper file, in which there is a higher taper that is needed in the apical portion and a lower taper in the coronal portion, where we don't need those big enlargement more, because our instruments today are more efficient, more cutting efficient, so they are safer, more flexible, and we don't need to do more the early coronal enlargement. When we still use the sequence of file, we change the taper and the tip of the file, so we enlarge more in the coronal portion when we work with a bigger taper, so that the root canal shape, the final shape, is not like in the single instrument where we stamp only one file and we know what we are doing exactly with that shape. But when we do a multiple file sequence, of course, we can have more risk to enlarge the coronal portion of the root canals. Okay, so we do what it is one of the concepts that is really important when using rotary files. The sectional cutting, that means that we change the tip size and the taper of the file, alternating the cutting area to reduce even the torsional stress of the file that, if not, goes to what was called taper lock. So when we start with a lower taper, then we pass to a higher taper. This means that the higher taper will cut only in the coronal portion, in the areas where the file is fatter, while the tip will be kept free. And we go through this process of changing the taper and the tip sides up to the point in which we arrive to the point in which we have an higher taper of the preparation, and then we go to enlarge with a bigger tip and lower taper to create what we called the apical preparation, the apical enlargement. That is the most important part of our cleaning, because if we don't enlarge enough in the apical region, we don't reach that region with our irrigants, and we don't clean that region from our bacteria. And again, alternating this cutting area create a higher taper in the coronal portion. The instrument's evolution in the last years of the rotary instrument was going through the process that we avoided the bigger taper in the coronal portion. So all the instruments that we have seen in the last years, they followed a different approach. That was we starting with a smaller file and increasing the taper and the tip sides together without the use of big fat files in the coronal portion. And with the possibility to use a coronal orifice opener or not, or start directly with the small file. This is an evolution that has been started in the past with the M2 files, and it was followed by many different concepts that even designed files by purpose for the minimal invasive shaping technique, like this sequence in which we had a small tip size with high taper, taper 6, that create a shape of the root canal. Then we go with a 35 apical preparation file, only taper 0, means that the walls of the instrument are parallel, and we go to cut only in the apical portion. And this is a sequence that, and we can avoid even the use of the 35 taper 4 or not. This was something optional file. But we can arrive to have a 35 diameter on the apical preparation with taper 0, where to put a plug, for example, in bioceramic. This is an intelligent approach because it creates a minimal invasive tapered root canal in the coronal portion, and then only the apical preparation. But this was started in the past with the M2 sequence more than 20 years ago, because they had the concept to start smaller. We started with a smaller file, then we increased the tip size and the taper without alternating, but just increasing the taper of the file and the tip as much as was needed by the root canal. And for example, after some years of use, I can say that 25 taper 6 was not useful at all. So we can stop the basic sequence to 20 taper 6 and then shift the 30 taper 5, decreasing the taper and increasing the tip preparation. So we assisted to an evolution of our techniques, because we started before with a big tip and big taper to create the early coronal enlargement, and then we passed to small file that just cut what they need to arrive to the apex. So we have an evolution of the approach to the root canal because we have an evolution of the instruments. They become more efficient, they become more flexible, and they become with an approach that we call it simultaneous, but in practice it is when we start with a smaller file and then we increase step by step our dimension of the file. And this led to another thing, that was that we don't use more the preflaring, so the extensive use of stainless steel before the mechanical files, but because we start with a smaller file and the pre-flaring was made with a really small file that is the same that we use for the scouting. So we simplified the procedure because starting with a smaller file, we have still to check, to verify the patency of the root canals before to go with the rotary files. But we can do it with a smaller approach, with a smaller stainless steel file, and this creates an easier procedure, much easier procedure. And even the last instruments that arrived on the market that are the evolution of what was made before with a bigger enlargement of the tip, they created new instruments with different innovations. That is the use of different alloys for different sides of the file, stiffer and stronger for the small file, a little bit more flexible for the medium files, and much more flexible for the bigger files. And this is a really important thing because sometimes when we applied the alloy of this flexible alloy to our instrument applied to smaller files, this can create instrument that they were not cutting at all. So now they understand that for a small tip or a small file, we need a stronger alloy. But even they suggest to use with this technique directly the rotary file without glide path. I have to say that I am not agreeing with this concept because I always start with a scouting with manual file because it is more from a practical point of view is really easy. Why I have not to make a little patency inside with a 10 stainless steel file when we can? It is something that is fast and easy, but make free our tip from the engagement in rotation and the risk of fracture of the tip. But anyway, this is an innovation even for these files. But what I call the best innovation, it is that these files are smaller on the top. So their main feature of the past has changed because we have files that are slimmer, are really thinner in the coronal portion. If you compare the old with the new, you see that that is the main feature. So they create the file that has the features that we want for the minimal invasive approach. The maximum diameter of the file that usually is in the coronal portion should be not bigger than 100, so that the preparation of the orifice is never exceeding 100 diameter, 1 millimeter. In the same time, we need a minimal preparation that should be higher of 80, 0.8 millimeter, because if not, we don't have enough space to deliver our irrigants, and we are limited with our obturation and sealing technique for the root canals. I want to underline that they changed in the ProTaper Ultimate. The manufacturer create a new shape for the enlargement that is no more triangular section, that today is an old section, the first that we have seen in the world of nickel titanium, but now they use a 2 blades cutting section. It's a square section, but it is a 2 blade cutting. that is probably the best way to cut in the root canal, because the two blades push on the opposite side and cut better when they get the dent in their blades. And you see that with this instrument, they are really effective. We can do good shapes, creating really small access, slim coronal preparation, but a higher taper and a good taper for the apical action and the apical obturation. So we have a minimal invasive approach in the coronal portion and a good cleaning and sealing of the root canals in the apical part. And these are the reciprocating instruments that they are 10 years on the market. And I want just to underline one of their features, that is that the 25 is taper 8 in the tip, but the diameter is 0.5, so almost inside our limits for the coronal preparation. And we see that the 40 and the 50, they are 1.1 and 1.17. So these files increase only on the tip, and they remain almost the same in the coronal portion. And even if they were old file, because now it's more than 10 years that they are on the market, we can notice that these files, they keep the coronal portion in their mind really thin. Okay, so the bigger files not only are conservative, but even more flexible, because the coronal portion is slimmer. So decreasing the taper and the dimension of the coronal portion, something that is really interesting for our files, because you see that even when the root canals are wider in the coronal, in the apical part, we can keep our pericervical dentin as much as possible without enlarging too much the coronal region, because that will be the tooth part that will sustain our crown in this case. And if we make it thinner, we make the tooth less resistant. And always is like this, even if when we have big apex and curved root canals, what we want to keep, it is the coronal portion. And one of the main innovation that in the last years we have seen on the rotary files in nickel titanium, it is the shift to martensitic alloy. So we moved to an alloy that is more flexible, and the new trends in endodontics that are the use of the stainless steel as less as possible. So to go only mechanical inside the root canal. The use of a single file approach without a sequence, so with a variable taper that stamp the its shape inside the root canal with a good apical preparation and a minimal invasive coronal preparation, joined with the new martensitic alloys, because the martensitic alloys are what make possible to realize all these innovations and these new trends. So the martensitic alloys create us the possibility to cut even less dentin. So we have to change our mind in the design of the cavity, because these files are more flexible and they progress easier toward the apical region. So we can create good apical preparation, good sealing of the root canal through a really small access in the coronal portion that permits to us to be more sustainable for our practice, because we create for our patient only a direct restoration, because the access is so small that it doesn't require the cuspal protection, so an overlay or even a crown, because we leave as much as possible the coronal tissues of the natural tissue of the patient. So this exercise of our minimal invasive endodontic should be considered something that is not useful, something that is just to show how much we are brave in the preparation of our cavity. I would say that today we have to talk of a dynamic approach to our preparation and to our coronal access. So what we do, it is to create a small access to start the scouting of the root canal, if we want, even directly with our mechanical file. This is up to the sequence that we want to go. If we are not able to arrive to the apex, to the working length, we enlarge the cavity access. If we are able to arrive, why to enlarge the cavity access? If we can achieve our goal, that is to have a good root canal shaping, especially in the apical region, why to enlarge more the coronal portion? It is no more needed. But this is an active feedback that we have from our instruments. If the instrument goes to the apex easily, don't enlarge more, start smaller. You see, you feel that you can progress easily. Okay, so once we open the cavity, the videos are a little bit slower today. Once we open the cavity, we start directly with a mechanical file. We see it arrives. And when we see there is an interference, we open a little bit more with the burr. We refine the cavity through all the procedures, activation of the file, activation of the irrigants, a big particular accent on the activation of the irrigation on the braiding procedure, because they are really, really important to achieve a good cleaning of the apical region. And then you see that even if we had to open a little bit more the palatal root, for example, but we left a good amount of dentin in the coronal portion, and this patient cannot afford a coronal restoration because it's not possible to pay for him. So we make for him a big favor, leaving the tooth with a big amount of natural tissues, so that probably that direct restoration will last more in the time. And we see here another procedure in which there are even calcification.
Recording in progress.
Use of the ultrasonic file to improve the quality of the preparation of the access. It's really important. They are conservative. And this is the final result. You see that we have a good access to the apical region with a really small access that can be completed with a really easy restoration, and a really easy restoration of the mesial decay. The important part for the success in the apical portion, the important part for the mechanical resistance, it is in the coronal portion. And today there is a big effort from the companies to give us something that improve this cleaning, even through smaller and smaller cavity preparation. This is the Sonendo, that is a machine that was created to clean the root canals without the shaping, almost with a smaller shaping possible, without as much as possible the use of the instrument. The results are promising, but still I cannot say it's something that it is diffused. It works with a sequence of endosonic waves that are pushed in the tooth with a device that is capped on the top of the crown. So it creates a closed environment in which these waves propagate and clean the space of the tooth. The instrument appeared like this. There is a spray pushed inside the tooth with different waves of hypochlorite and alternated with other lipids. This approach has been already proposed in the past because a non-instrumental technique was a technique that was proposed during the 90s, and it was a similar action with a pump that pull out from the root canal the materials. The inventor of this technology was Lucy, Switzerland endodontist. But this is science or fiction? We still don't know, because there are not really enough proofs that the system works. For example, the non-instrumental technology was abandoned after 10 years of claims and promises. Today, we still have to go inside the root canal with our instrumentation to have a good apical preparation, a good apical arriving of the irrigants. And then if we want to use even this kind of machines, can be good. And again, the technology has to be delivered for quality and sustainability. Because if these machines are too expensive and people cannot afford the price of the cost, so they are not useful at all. We see now a case following the concept that we have seen before. So there is a big caries decay in the first upper molar. I suggest always to do bite wings when we see the caries, and then follow it by a periapical radiograph, because the projection are different and we can study better how to approach our coronal portion in the bite wings. There are people today that are suggesting to do the CBCT even to plan the cavity access, but this probably is too much, in my opinion. If you have a CBCT, you can take a look to that to study how to open the cavity, but a radiograph in two-dimensional are enough. So after this, we can notice two things. The patient is young, and the root canals are big. And we can approach through a mesial access our endodontic procedures. How to do it? The first thing, usually from a practical point of view, I put the rubber dam on two teeth before, so that I can start to work directly with the rubber dam. But once I remove the coronal portion, we can put the rubber dam in the correct way. This way, it's for starting without cutting the rubber dam when we open the cavity. So you see that after we remove the enamel and we cut the mesial portion, we put back the rubber dam. I use many times wood wedge to stabilize the rubber dam. And we clean all the infected dentin with our burrs without cutting unuseful portion of the tooth. Once we arrived in the pulp cavity, so once we arrived in the pulp cavity, we have to see where we are. We have to visualize our pulp space and to visualize all the root canals. As you see here, from this small hole, that was the hole that we made, the cavity that we made, only to remove the decay, only to remove the big undercut of the enamel. Not all the undercuts, but we can still leave a small of the undercut of the enamel. And so we follow what I already showed up as our principle in the shaping of the root canals, okay? In the preparation of the cavity from the coronal to the internal part of the root canal. We start with the smaller access possible, and once we arrive inside the cavity to see the root canals, we start the preparation. Okay, if the preparation, scouting and glide path is enough and is comfortable, we don't enlarge more. If the preparation is not possible, we enlarge more our cavity. And it is what we did here. From a smaller access, we try to go with our instrument of choice that can be rotary or reciprocating. I suggest to use for the bigger files martensitic alloys. For the smaller file, not. It's better an alloy that is a little bit stiffer. But whatever is the file, we can go inside the root canal, verify if the root canal is difficult or not. If it is difficult, we enlarge more. If it is not, we keep that dimension. And you see that we were able to create a good apical preparation, a good apical sealing with our sealer, with our materials, without enlarging more than what we did before. We have an MB2 confluent in the apical portion of the mesial root. And this is the residual cavity. It's really small. So you can make a service to the patient if you can follow this kind of approach, because you will give to the patient the possibility to make a cheaper, well-maintainable, long-lasting restoration. Okay, he will spend less money and have more in terms of sound tissues, because the price of our tissues is really priceless. Because when we remove the enamel, we cannot more replace it. When we remove a restoration, we can replace it. When we remove something like the gum, okay, we remove a portion of the gum, it will be replaced. But if we remove a portion of the enamel, we cannot replace with any material. There is not anything that is as good as our sound, healthy, hard tissues. And you see here that the philosophy of the conservation follow even the restorative dentistry, because there is a decay, in this premolar, and we perform a good approach, keeping what was important for the mechanical resistance of the tooth, that was the marginal ridge. And you see that here we are able to make the restoration from the distal axis, but it is important in this situation to have the good materials, because we have to go in the undercuts of the enamel where the caries spread, because the caries is spreading in the portion of the tooth where there is the limit between the enamel and the dent. So it is important to have this dimension so small inside our cavity, so that we can perform at that point an easy treatment. And we see again here that we can see all the root canals, mesial, MB2, all the root canal orifice, distal and palatal, because we move our head with our microscope or with our loops, and we see inside, because the light is concentrated and there is much more possibility today to make the light go inside. Before, when the light was not so efficient, we have to enlarge the cavity to see inside, not only to access with our instrument. So once we have this kind of cavity, I use a resin composite bulk fill inside the cavity access, bulk fill even in the marginal ridge reconstruction, because the bulk fill is an easy material that it's easier to manipulate and faster to build up. And then I reconstruct with the resin composite only the coronal aspect of the tooth. Okay, so I reconstruct only the final shape of 2 millimeters and the final layer of 2 millimeters. And you see that with this kind of approach, to put in the functionality of the tooth, to restore the functionality of the tooth is much easier, because the cavity is so small that you follow the natural profiles, and it's much easier to obtain really good occlusion, and in the same time, a really good interproximal bulky shape, because that area is the most difficult to reconstruct when we lose the tissues, okay, because it is in the interproximal area, but it is important for the maintenance of the hygiene in the interproximal zones that are the more delicate in terms of residue of the decays. So we can change our clinical plans if we have an occlusal access or an interproximal cavities. We will create this kind of approach. Interproximal, we put the matrix, the wedges, and we create from the beginning the final shape of the tooth, tighten with the interproximal area. So we restore with the flow the wall interproximally. Then we fill up with the bulk fill up to 2 millimeters shorter from the final layer, and then we can use a final resin composite that is harder to the abrasion for the final surface. This is an easy procedure, and of course we will use only bulk fill that can be incremented of 4 millimeters each time, and resin composite for the final 2 millimeters for the occlusal cavities. Okay. Pay attention to the pulp horns, of course, because in the pulp horns that can be a lot of pulp, lot of bacteria, a lot of necrotic tissues. So we have to clean them mechanically. We need something to go there and clean when we know that they are there and we left them because the cavity is small. It is the only area that we have to take care. And I do it like this with a chuck that you can turn in different directions to go distal, mesial, palatal, where you want. And this is the use of this file. Let me check. Okay. The videos are a little bit influenced by the line, and but the concept it is that we can go with that shaped ultrasonic in this area. So we can go to clean in the undercuts of our pulp horns that are located here. Okay, it's the only way that we can do. Another concept it is the strategic planning of the cavity access. For example, when we have a restoration, where it is, how much it is extended, how we can use the restoration to go inside the crown of this tooth. Okay, and we see that here we have an extended restoration on the occlusal surface that is not so extended in the deeper part of the dentin. So what we can do it is to remove whatever we want of the restoration, even all the restoration, it is important to remove because we don't need the amount of dentin of the restoration. It's not needed at all. So we see that here we will be more invasive where the restoration is. And we have to change our position to localize, for example, this MB2 that is located under this undercut. And this is important. We have to see all what we are doing, because if we don't see, we are not able to treat. So we have to see inside, even if the small is small, the cavity is small, we have to see inside. And you see that here we make a really big bevel on the distal side so that we can go inside better, because that was resin composite. And this is the situation before the preparation of the MB2 with this really difficult insertion of the instrument that was really bended by the interproximal. And finally, what we obtained, it is this removal of the dentin to approach the MB2 that was impossible to do not be done. And now we have a good line to enter inside the MB2. And again, we can arrive with a good apical preparation, with a good apical sealing, but keeping as much as possible the area that we started to define pericervical dentin. The thickness and the height of that portion, it's really important. And if we can do not this straight line, but this kind of approach, keeping that thickness, saving that thickness, this is a big favor that we do to our patient. So we have to go to design cavity like the ninja ones that we see in the internet. This is good. This is too much or not. So the ninja can be defined as a really small hole, smaller than 1.5 millimeter. This is a really, really small. It is possible to be done? Yes. I checked the video on the other phone. MB1, MB1 here, MB2 here. Martensilic file working inside. You see that even through this really, really small cavity, in a particular tooth, it was like an experiment in this case, we were able to make a good apical preparation through the really, really, really small access. But this ninja that we defined as a really small cavity, the smallest possible, is something that is useful. When we did some tests, we have seen that the ninja or a conservative access at the end, there is not a much different. So in real clinical condition, to keep the really small access as not a biomechanical advantage. The teeth with a small access and a little bit bigger, a conservative one that keep the pericervical dentin, that is the most important part, is better. And even we did another research with the University of Siena about the truss access, that is to keep this bridge on the top of our tooth. And we performed all the cavity and the restoration. And again, testing with mechanical, with the universal machine. And we have seen that the conventional and the truss axis, they were almost the same. There are no statistical difference between them. Another study that we did with finite element analysis, we reconstructed the teeth with a micro CT scanning. So it's a real tooth. From the data, we are able to reconstruct the crown exactly as our natural tooth, with all the components, the enamel and the dentin, the pulp, space, dimensions, everything. So starting from this kind of 3D model, real 3D model, we prepared a virtual cavity design. So we have the intact tooth, completely intact. We have an under-prepared access, so ninja, and a classic one, together with a high taper or a low taper or a variable taper preparation of the root canals. So we didn't analyze only the cavity, but even the amount of dentin that we remove inside the tooth. And we have seen that the main variable was the orifice enlargement. So the portion that is more important for the mechanical resistance, even with this test of the finite element analysis, it is the coronal portion. How much we remove in the cavity itself on the occlusal surface is less important, and not only, the apical medium portion are not influenced. They don't have any influence on the mechanical resistance of the tooth. So what is important, it is the thickness that we leave in the coronal portion when we design the cavity access. So we are not so linked with this really, really small hole. We just make something that create the possibility to see inside the tooth. And of course, if we can keep the marginal ridges always, it is important because those are the most important parts for the mechanical resistance, especially when we plan for a partial restoration, like an overlay or a tabletop. So we don't want extremism. We don't want to be so small and ninja and exaggerate, because we want to follow principles that are we call VUA. The VUA principles means visibility, vision, and accessibility. So even through a small hole, you should still to keep to see inside, okay? To visualize the pulp chamfer floor and all the root canal orifice. Even if you have to move your head or your microscope, it doesn't important, it's not important. So in this cavity, for example, we see the mesial, we don't see the distal. We see the distal, we don't see the mesial. But this is not important. We see everything what it is important to create a good shape and a good restoration. Whatever it is, the tooth, whatever it is, the anatomy. And the accessibility, this means that we can arrive in our root canal space easily with a good approach, and we have to be able to see the pulp floor in all its features. So all the digging, all the connection between root canals, we have to see them, because if there is an isthmus, we have to go to clean. We have to see everything, okay? As you see here, in this micro CT scan, for example, there is an isthmus between the distal and the palatal root canals of this upper molar, with a big amount of stuff inside. So that portion should be cleaned. But if I don't see it, how I can clean it? So we have to create a cavity that permits to us to see everything inside the root canal orifice, like this. And you see that we can see good, even if the cavity is really small. But we don't want to do as small as is possible. We do the cavity that give us the possibility to access and to see everything. And you see here that we create this bevel in the enamel almost always, because we have to avoid that our instrument have an interference there. So the instrument that goes in this root canal can have an interference here, and we have to avoid to have that coronal interferences for our instruments. Always like this, to keep as much as possible our pericervical dentin and the cavity on the top. When we go to see the data of our studies that we performed, we compared these cavities. In red, we can see a ninja. In green, we can see a conservative approach like we like to see and access. And in purple, we can see a traditional cavity. These are ideally what we have. And we measured this kind of amount of removal of the dentin and enamel, and we have seen that this is a conservative approach like we like. We suggest this because through the smaller like this, we don't see inside, and it is really difficult to access all. And we measured that with the ninja approach. Usually we remove from 0 to 6% of the coronal portion of the volume of coronal dentin and enamel removed. With the correct approach of the conservative endodontic cavity, it is from 6 to 15%, and more than 15%, it is a traditional cavity access. So that we can improve even the communication, because if I say ninja, I don't know how much ninja it is. If I say that I make an ultra-conservative cavity, I see that, okay, it is 6%. So even between researchers, it is important, a good communication, okay? So this is a ninja, this is a conservative. It's a little bit bigger, but permits to us to do what we want. This is the point. This is what we want to see. We want to see all the root canals inside. We want to approach all the portion of our endodontic axis. And I want to show finally even that what it is important is to keep the dentin. So we see here, we make pre-reconstruction, the isolation of the tooth, and so on. Oh, this video is gonna be okay. So once we access all the roots and root canals, prepare the tooth, prepare the root canals, we have even to decide for the preparation of the crown. And I like to do my restoration on the teeth that I treat. So you see here that even from this point of view, the more tooth we leave there, the better it is, okay? So when we think about the pericervical dentin, that we can even talk about ferrule, it is the same thing. Thickness, height, and number of walls are the variable that we have to take in consideration. If we save dentin from the inside portion, as we told before, with a smaller preparation, we can see that we can even save some kind of tooth even from the outside. Because when we go to the finishing line of our crown, in this case, it was mandatory, we work from the inside, but we work even from the outside. So if from the outside we create a preparation that cut a lot of dentin, we reduce the amount of the tooth, even from the outside. And it is a terrible mix. So for example, the chamfer is a kind of finishing line. The shoulder is another kind of finishing line. And we use, for example, many times, the feather edge finishing line. Why? Because the thickness of the wall at the end of the original tooth is much more well conserved. So even this kind of conservative approach in the restoration with a complete crown coverage, it is important because what we leave under the crown, the thickness of the portion, it is one of the most important parts. And we have this kind of approach that today is worldwide diffused by Italian prosthodontics. And we see the final preparation that there is any kind of finishing line. It's straight and respect much better the tooth structure, and even you can change the line of the preparation where it is resin composite, I cut more. When it is tooth, I cut less. So we save a portion, a really important portion of the tooth, to have the final restoration that is biological accepted with a good basis and a good portion of internal part. A final case, yes, that this is a difficult case because in this case we had a retreatment, we had used a three-dimensional post that is milled. And this is an article we wrote more than 15 years ago, in which we described it to adapt the post to the root canal anatomy, even to be conservative. And you see here initial situation, bleaching, and you see this is an adapted post. This bigger, wider, because the tooth was destroyed, while in the tooth where there was a perforation, of course, but we keep a normal post, and this was the shape of the preparation, a micro-ledged shoulder that create this final result, and this final result internally and externally. I think that now the time to speak with me is over, almost over. There is the time for questions. I thank you very much for the attention. That is my mail if you need some more information about this approach. And again, thank you very much for the attention, and it was a really pleasure, and I'm here for the question. Thank you, Dennis, and all the faculty staff that are present here.
Thank you very much, Prof. Nicola, for your fascinating lecture regarding minimal invasive endodontics. The lecture is very interesting about how to maintain the sound dentin, the sound tooth structure, especially during the coronal access preparation. We need to maintain, more specifically, is the pericervical dentin. This is the critical area that we have to save. The more we save the hard tooth structure, the more we can increase the fracture resistance and increase, of course, the success rate and the survival rate of the tooth. Now I think we can take some questions. If anyone of the audience has any question, please feel free to ask Prof. Nicola. We welcome a couple of questions.
Of course.
Yes.
Dr. Dennis, can I ask
Yes,
a
sure.
question for
Please
Prof.
introduce.
Nicola
Yes.
Grande?
Yes.
Okay, thank you so much for your lecture, Prof. Nicola. Your knowledge and sharing means a lot to me. I have two questions. The first one, I appreciate for your explanation about the ninja access and conservative endodontic cavity, but what's your opinion about the opportunistic endodontic cavity, or we call it caries-driven endodontic cavity? That's the first question. And the second one, if we do the ninja access, is it any advantage on the fracture strength of the tooth after the restoration? Thank you.
Okay. Yes. The opportunistic access is, as I explained, you go through the cavity or through the caries, and you remove all the tissue that are decayed. Then from that hole, you go inside the root canals, and if it is needed, you enlarge. So for sure, I agree with the opportunistic approach. And as I explained, the ninja cavity toward the conservative cavity, it looks like it doesn't give to us any real advantage in terms of biomechanical. So because it saves only on the top of the floor. But when you do a small cavity on the top, then you have to enlarge down. So you have not a real advantage in terms of thickness of the walls. It is just a little hole on the top. So there is not any difference of resistance.
Okay, Prof. So there is no any advantage on the fracture strength?
No.
Okay, on the different type of the access cavity, Prof. Okay, thank you.
Almost for the literature and tests that we have up to now.
Okay, thank you very much, Prof.
Yeah, thank you, Prof. Nicola, for the answer. Please, anyone, please feel free to ask if you have any questions. We have one question in the chat box. What's the main etiology in failed endodontic treatment that most common happen in endodontic treatment? What is the main cause in the failed cases? Yeah.
I understand. Let's say that from my experience, but that is not important, from the literature, the failure of endodontically treated teeth, the most frequent is fracture. And this is enlightening, this is, clarifying an important concept that if we cut too much the tooth and we don't take attention to the restoration, the mechanical failure of endodontically treated teeth, it is the most common reason of loss of teeth endodontically treated. Then, of course, there is even the loss for incomplete root canal treatment, but the main failure, it is mechanical. So for this, we underline the concepts that I explained today.
Thank you, Professor. It answered my question.
You're welcome.
Another question. What's your suggestion if the file is broken in apical third? When do we choose to retrieve or bypass, since the pericervical dentin will be much sacrificed if we choose the retrieval? Thank you.
Okay, my approach, if the file is in the apical third, in a long tooth, that is a big problem. And for the bypass, always try to bypass, because sometimes you think it is impossible and you do it. So the bypass is the first approach. Then if we want to try to remove the file, always with the microscope use and ultrasonic tips dedicated for this aim, let's say that we have to carefully evaluate the alternative of a surgery before, because sometimes it is not needed. You leave the file there, you obturate the root canal, and the tooth is okay. So you make an observation of the root and of the tooth in question, but you have to decide before if you have the possibility for a surgical access to that area. So for example, if it is a second upper molar, it is more difficult. A lower second molar, it's almost sometimes impossible to do the apical surgery. But if it is an upper molar, it is possible. If it is a premolar, it is possible. Anterior is possible. So let's say that we carefully evaluate before the approach possibility by surgery in a second time, doing a CBCT and evaluating the accessibility of the root. But usually is to go to cut the dentin to arrive to see with the microscope in the apical portion, it's really challenging.
Yeah, thank you.
Pre-flaring,
Yes.
probably.
Yes, pre-flaring.
Okay.
The coronary flaring still necessary?
Let's say that we use instrument, they cut for themselves. So when you go with the first file, it's enlarging and going down. So I would say no. It's better to do not do early coronal enlargement so to enlarge before the coronal portion. These files today, I have the possibility to progress and cut exactly what you need to arrive to the working length without more.
And how about the danger zone? Danger zone, Prof. Nicola?
It's no more danger with the file, modern file, because they are more flexible. They don't go to cut too much in the internal area where you can make a perforation. So, because it was dangerous zone when we enlarged it a lot. Okay.
Okay. Thank you, Prof.
You're welcome.
Thank you, Prof. Nicola, for your answer.
You're welcome again. Prego, grazie mille, prego.
Another question?
See, I read it. It is mandatory to make cuspal coverage. No, because as I showed in my cases, when you have a really small access, sometimes you can avoid to make the root coverage. So it depends on the loss of the marginal ridge. Usually, if the marginal ridge mesial is lost, we cover the two cusp mesially. But if you have been a really, really small access, sometimes we avoid even this. If the distal marginal ridge is lost, you should cover the distal cusps in the molars. This is, but anyway, it's not mandatory if the cavity is really small. If the cavity is a normal, bigger cavity and the loss of tissue before the treatment is high, we have to cover the cusp, of course.
There's another question.
In preparation, the enamel pearl. Let's say that this is, in the particular cases, we have to make the cavity enough to achieve our result. So if there is an enamel pearl, you remove the enamel pearl and to increase the cavity. It's not always possible to do a really small access. If the root canal is difficult, you enlarge more. If you use not the microscope and the loops, it is you need to enlarge a little bit more because your tool is a little bit less performant. So you have to adapt the cavity to the situation and the removal amount to the situation. The less we cut, the best it is, the better it is.
Thank you.
Okay, Dr. Dennis, can I ask some question?
Please.
Thank you for Professor Nick. It's a wonderful lecture. I'm curious about how to make the predictable to remove the pop horn. As you say, must be careful to remove all the pop horn in the if we have access in the small area in the proximal, what you do if you want to make sure the pulp horn is all removed with the bending. I'm not sure I can see the picture. Can you explain again, Prof?
Yes. Let's say that we cannot see. The only part that we cannot see is under the pulp horns,
yes,
because of course it's impossible. We have not a micro mirror or an endo. You should need something to go to see from inside, so it's impossible. But I saw that if we go good with the ultrasonic tips, as I showed, curved ultrasonic tip that you make by purpose, when you see that the pulp horns is there, usually the proof that you make it empty of material, of pulp, of debris, it is that you inject inside the restoration material. You see clean pulp horn injection with the composite or with guttaperca when you close the root canals. So that is an indirect proof that we did a good job.
Yes, I must be. It's very difficult to gain the. No. It's just make a like a ultrasonic and calcium hypochlorite.
With the right tool, it's not difficult.
Okay. Thank you, Prof.
You're welcome.
Thank you, Prof. Maybe I want to ask Prof. Nicola, do you have any tips maybe to maintain the coronal tooth structure in the case of previously treated tooth when we want to retreat the tooth?
Always following the same approach. You remove before the material, all the material that is on the top. Then if there is some tooth to be saved, you try to go inside the root canal as much as possible conservative. Sometimes we have the post, for example, metal post or fiber post to be removed. And in that operation, we have to be careful because sometimes we enlarge a lot on the top, we remove all the tooth to remove the post. So it is just a question of careful evaluation of what it is mandatory to remove and what we can leave there even in the retreatment is more difficult because in the retreatment, of course, if we are retreating, it is because the tooth has been failed and we don't want to fail again. So it is important to be effective in the cleaning and in the shaping of the tooth. So it's more difficult to be conservative. Usually even because when they did the treatment, they were not conservative. So the tooth is already...
Yeah, sometimes there are a lot of damage at the coronal portion.
Yes.
By the previous clinician. Yeah. Maybe we can have some questions. Please feel free to ask if the audience or participants has any questions.
Mungkin kalau dengan bahasa Indonesia, Dr. Dennis boleh bantu translate ya.
You can also ask in bahasa and we can translate in English. Please.
Ayo silakan.
Don't hesitate. Especially our postgraduate students.
Yuk silakan residen konservasi. Ini kita ada juga alumni nih. Mungkin alumni ada yang ingin berdiskusi, Dr. Dennis.
For our alumni, also we welcome. Just feel free to ask. for our students, postgraduate students, our alumni, colleagues, fellow dentists.
Mungkin boleh ditanyakan dalam bahasa Indonesia, nanti Dr. Denis bantu ya, Dr. Denis.
Ya.
Oke, silakan Residen.
A little bit shy.
Ayo silakan, Residen. Jangan malu-malu. Bisa dalam bahasa Inggris atau bahasa Indonesia, dia akan diterjemahkan.
Sepertinya di chat box ada Dr. Denis.
Oh, chat box, okay. One question in the chat box. What is your suggestion for endodontic beginner about this approach?
Oh, yes, the beginner of the expert is the same. You change the approach. Before you designed the cavity always the same. Today you start smaller and then you enlarge more. If you are a beginner, you will enlarge a little bit more. With the experience, you will enlarge less. So it is something that it is tailor-made for each tooth, but of course, it's even depending on who is the tailor. So experience will lead for better results. What it is important is to follow the correct principles. The principles is to go smaller, to be conservative. If you follow that, you will start with a bigger cavity. But then in your mind, you will have how to work in a good way. And so you will improve for sure.
Maybe for those that they don't have any magnification device. Yeah.
Yes, but the principle can be always the same. Of course, if you don't have the magnification to see and to have access, you will enlarge more. But you know that there is the possibility to go in that direction. Okay.
Do we still have time?
If there are no more questions,
I think, yeah. Still, is there any question? If no more question, I think we can close. Oh, one question: does loop magnification is enough?
Loops are better than nothing, and you can do a lot of work with the loops. But the microscope is better.
I think now is the time. I think time is, yeah.
Okay.
Okay.
Thank you again for everything.
Thank you very much, Prof. Nick Grande, for your enlightenment, for your lecture, for your insight. You give us a very good enlightenment, good contribution by sharing your knowledge and experience. We would like to thank you once again for your precious time, for your lecture this morning in our time and afternoon in our time. Now I want to return this session to the MC.
Thank you very much, Professor Nicola and Dr. Denis, for the interesting topic and discussion. And now, the certificate for this session will be given by our Dean, Dr. Esi Oktiara, to Professor Nicola and Dr. Dennis as an appreciation from us.
Thank you to Professor Nicola and Brandi as our speaker today for sharing your knowledge in our webinar today. Faculty of Dentistry of Universitas Sumatera Utara giving you this certificate as our appreciation for participating this webinar. We welcome you to take this certificate, Doctor.
Thank you very much.
Thank you, Doctor. Hopefully you will willing to participate in the next webinar. Thank you.
Thank you. Thank you.
Dr. Esi, there is a certificate of application for Dr. Dennis, please. You are in mood.
Sorry. Thank you for Dr. Dennis as moderator for this webinar. We welcome you to take this certificate, Dr. Dennis.
Thank you very much.
Okay, thank you, doctors.
Thank you very much, Dr. Esi, Professor Nicola, and Dr. Dennis. We have come to the end of our webinar today. We would like to extend our gratitude to our amazing speakers. Thank you very much for sharing your insight and experience with us today. We hope these amazing speakers have inspired many people out there with their presentation. We also would like to thank to the moderators and to all participants for staying with us until the end of this webinar. I would like to extend my apology for any wrong words during the webinar. It's been a pleasure being with all of you today. I'm Intan, signing off. Thank you for joining us and have a great day. Assalamualaikum warahmatullahi wabarakatuh. Good evening.
Thank you very much.
Bye-bye.
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 See you.
Ciao.
Ciao. Gracious.
Thank you, Prof. Thank you, Dr. Dennis.
Thank you, Dr. Wanda, Dr. Esi.
Terima kasih, Dr.
Terima kasih, Dr.
Esi.
Tami.
Thank you, Doc.
All the shine of a thousand
Yeah. Murni.
Terima kasih,
Dr.
Prof.
Ami. Terima kasih, Ami.
never be enough. Times ago are still too little. These hands could hold.